I'll share my screen in 2 minutes and we'll get started.
Let's start. Yeah.
One minute, madam. Something is going.
Hi Charmila, welcome. Charmila को unmute किया ना?
So hello everyone.
Hello.
Good afternoon and welcome to this wonderful session of day 2 of our journey of preventive oncology, where we are talking about cervical cancer elimination. So this journey started yesterday on Vasant Panchami and Republic Day. What a coincidence, when we really wanted to talk about cancer-free Mukt India, and exactly we started at the Republic Day. So thank you very much, Dr. Lakshmi Madam, to allow us, to give us this opportunity to convene this program along with my co-conveners, Dr. Mala Srivastava, Dr. Revati Janakiram, and along with Dr. Bhagya Lakshmi Naik. So today we have again a set of wonderful tests, and we do have Dr. Charmila again with us, who is the series convener. So thank you very much. And I would like Dr. Lakshmi Madam to welcome everyone and start this. Yes, madam. Yes. Your remark as ICOG chair.
Yes. Very good evening, all dear faculties, all the respected teachers, seniors, and dear friends. Yesterday, it was very useful and informative session. Priya, I must tell you, my personal chat box is flooded with the praise of yesterday's session. Everyone is saying it was so useful, so informative. And I'm sure that today also our session will be as useful as it was yesterday. And the full credit for this success, I give it to Priya Ganesh Kumar along with her 3 co-conveners for the selection of topic and the selection of speakers. So without wasting much time, let us now start with our day 2 session, and I hand over back to Priya for further proceedings.
Thank you, madam, and congratulations to you for getting so much of congratulatory messages. And we have with us Dr. Parag as well, Vice President of ICOG. Welcome, Dr. Parag. And today we are starting our day 2 program. So today, how are we going to go? Let me go take you through this. Today's how are we going to do it? So today we have wonderful talks. You can go through these things. We have HPVS primary screening, Bethesda, tissue biology of CIN, VIA, VILI, IHC tumor marker, and then augmented screening with new AI device, setting up of a colposcopy unit, and digital reporting with SSNPP app. So this is all. So today we are going to have a pre-test. It's not a test, of course. We are not supposed to say test. It's just a pre-course topic evaluation for your own understanding how we are going to get the post-course also. Again, on the same day, Dr. Mala will take you through that. Then we have the revision of today's yesterday's topics by Dr. Bhagya Lakshmi Naik. After that, we invite our chairs, and then we start our scientific session. So that's today's way how we are going to go forward. So Dr. Mala, over to you. You can unmute yourself, Dr. Mala.
Good evening, everyone. Without wasting time, we just move on directly to the pre-test today. Mr. Jignesh, you can share the questions. We have set of 30 questions for today as well, for 10 topics which are to be discussed. And we have framed the question in such a form so that you have the elaborate knowledge of the subject, and you can also check your knowledge after the lectures are over. So Mr. Jignesh, please share the questions for the participants.
Yes, ma'am. Share the link.
Okay. And we'll give you 10 minutes for you all to answer them. That is 20 seconds per question.
Yeah, so your time starts now. Timer here has started. Please start answering the questions.
Yeah, and we don't want to discuss anything in between so that you're
Yeah,
not
so we all
disturbed.
will be muted. We will keep mum. जिग्नेश लिंक एक बार फिर से शेयर कर दो. करेक्ट. Wow, Sadhana, great. सब कुछ उसी में.
Priya, question number 23. There's something wrong in that.
We will take care of it during.
So don't worry, that 23 will be ignored because there was
Okay.
some typing error or something.
Yeah, exactly.
We identified it prior itself. So we have erased that thing.
Great. So according to Jignesh timer, it is over. Jignesh, stop that link now.
Done, ma'am.
Yeah, great. Now, Priya, please proceed.
Yeah. So now we will be moving ahead. So today is our day 2. And we have yesterday covered many of the topics, and today's topics and faculties are also equally excellent as what we had done yesterday. And today's topics are all these topics. Now I hand over this session to Dr. Bhagya Lakshmi for the previous yesterday's revision. So over to you, Dr. Bhagya. You get 10 minutes to revise yesterday's complete topics.
Okay, thank you so much. Thank you, Dr. Lakshmi and Dr. Priya. And I think it has been really, really very encouraging. I think many of the people who have got the feedback have started joining today. So I think we should encourage them also, because I've got many calls that can I join today? I told yes, that's fine. No issue at all. So I think it was very interesting that we had all the top leaders with us, Dr. Madhuri Patel, Secretary General, Dr. H.D. Pai, President FOGSI, who gave all the plans that they have for FOGSI. And I think Dr. Lakshmi, as the chairperson of the ICOG, has been doing tremendously well, and this is in sync with the Badlao changes that Dr. Pai is planning. So I think we had very interesting messages from all of them, and we started with the scientific program with Dr. Usha Saraya Madam's talk, in which she discussed about the preventive oncology status in India, and I think tremendously well she explained what all we need. We should not be competing with the tests that we have in hand. So each test is complementary to the other. Each test tries to tell us something else, something about the disease. So I think each test is complementary. Until you have your HPV, you can do your cytology. Until you have cytology, you continue with your VIA. But please do, and as madam has told, that involve everyone around, make it a good your clinic should be a welcoming attitude for all the women to come, so that they don't think that they're going somewhere else, some to a place where they'll have diagnosis of some disease and keep them in awe. So we should always have something good to tell them. And I think Dr. Lakshmi also explained so well about the global call for cervical cancer elimination, that I think we are working in tandem with the WHO call which has been given, and I think India has been a signatory, and FOGSI as a very, very important wing or part of India is doing tremendously well under the leadership of Dr. Priya, because they have, I think, toiled too hard for spreading the message of cervical cancer awareness among all the doctors. So I think now it has become a household term with all the gynecologists, that everyone talks about cervical cancer prevention, about colposcopy and all those things. So I think Dr. Lakshmi, thank you so much. And then we had HPV vaccination guidelines from Reena Srivastava madam. And I think the new thing that we all have to know about vaccine is that we are going to roll out the Indian vaccine soon. And it's a single dose vaccine which has been recommended by WHO just in I think it was in November that the SAGE guidelines of WHO has come out, that we can give one dose between 9 to 14 years and also 1 to 2 doses between 14 to 20 years. So we are very optimistic about that. So I think in the meantime, we have to do something to sensitize mainly the school children, the school teachers and the parents of young girls, so that when the vaccine rolls out, I think they should accept it very well. We should not face the same hitches which we had with the corona vaccine. So I think that's a good thing about vaccine. And then we had the guidelines from Dr. Shalini Rajaram, who spoke to us about the screening guidelines about FOGSI GCPR, and they had been made under the leadership of Dr. Neerja when she was the chairperson of the Oncology Committee of FOGSI. And we all had worked very hard to make them happen. And they are there on the FOGSI website, and we have guidelines for all resource settings. So as I think we had also Dr. Paul, who told, and he appreciated that we have this screening for every resource setting. So it's not necessary that we should have HPV. It's not necessary you should have cytology. You can have a little acetic acid only if you put it on the cervix and look at the cervix. So I think we should not lose the habit of doing a speculum examination, which is very, very important. So we have screening guidelines for all the resource settings, and all these guidelines are there on the FOGSI website. So kindly look up the FOGSI website, download the screening guidelines and GCPR for screening, and continue to practice until we have a newer model now. Then we had our excellent talk by Dr. Priya Ganesh Kumar on ASCCP 2019 guidelines. So that though they are American protocols, they have been worked very nicely, and I think they really follow a risk-based treatment of this. They really don't follow a single report of a cytology or a single report of HPV and start screening. So theirs is a really mainly a risk based treatment management, and then we have to know the risk of the woman developing into CIN3 and plan the management. So they are also very excellent ones. And the latest WHO guidelines which I spoke about is basically about that WHO is expecting all of us to move from cytology to HPV based screening, but until we have, again, we can do anything we have. So, and the HPV screening should start at 30 years, at least 2 times screening. And if she's a woman with HIV, start at 25 years and do it again regularly at 3-yearly interval. So that's the WHO new guidelines. And then Dr. Sundari, I think that was excellent talk to arrange screening camps. And I think women who, doctors who arrange screening camps only can tell you what the hardships you really feel when you go out to the communities to work. So I think, but then please please get in touch with NGOs working for this screening programs, small programs you can start with, maybe with awareness programs in your local communities. And then we have stalwarts like her to help you out if you have any problems. So then we have Dr. Alia Begum, who spoke to us about screening in LMIC countries, especially about Pakistan's experience, and they are almost the same like us, in contrast to Bhutan and Bangladesh, which are much ahead of us in screening, though they are very small countries. So we have so many things to learn from them. And then I think the icing on the cake was Dr. Paul Blumenthal, who spoke to us about the screen and treat approach with the cube pad, and that was really extremely interesting, that we collect a bit of a scrap from the menstrual pad, and we tested for HPV, expecting the result in 10 minutes, and then do a thermal ablation of the cervix. So I think we are still, that's a dream come true. I don't know when we will get it in India, but then that is a vision, and we all should work towards that. And then last but not the least was a very excellent talk by Nirja Bhatla madam, which was about the new FIGO 2018 staging of cervical cancer, which is, because she tells, why should we tell it is new, because it was in 2018, but until we have something new, till then it is still new. So I think the 2018 staging system has taught us a lot of difference than the previous ones, because here I think we have divided that 1B into 1B, 1, 2 and 3, because we know that the larger lesions really do not respond much to radiation or surgery and have a bad prognostic factor, is a bad prognostic factor as compared to smaller lesions, even with nodal metastasis. So there are so many new things in the FIGO staging system, and I think we have also allowed, because initially the FIGO staging system was only on clinical examination, but now the recent FIGO staging has allowed us to do a radiology, to use a MRI, to use a CT scan, whatever you have in hand. But then if you don't have anything also, a good ultrasound done by a good sonologist in a good machine by a transvaginal or transrectal method will also tell us very correctly, maybe sometimes better than MRI, about the parametrial extension and about the growth size and all those things. So that also you can take help of. So use your imaging also to stage your disease, plan treatment, so that we do not have to give 2 modalities of treatment to the cervical cancer patient. If you think she will need radiotherapy, send her for radiotherapy. If you think she will need only surgery and no adjuvant treatment, take her for surgery. So try to give the best to your patient with your clinical acumen, with your imaging, with your histopathology, and talk to your seniors, talk to your senior friends, gynae-oncologists, and make a very good treatment for your patient, plan it very nicely. So thank you very much for giving this opportunity. And it was really a very interesting session yesterday for those who have missed it. But I think again, we are looking forward to the coming today and tomorrow to be equally interesting. Thank you so much.
Thank you, Dr. Bhagyalakshmi. So this was an excellent overview and a short revision of what we had done yesterday with all the topics. Now, today's topic is, we are going to now see, yesterday we spoke about overview of how we come up with the guidelines and overview of understanding. Today, we are going to talk, today's whole theme is on the clinical. We have several screening tests, isn't it? Now we are going to deep dive on each of the screening tests and understand relevance about it on your clinical setup. In your clinical setup, how are you going to have the relevance of various screening tests? And I like to share the screen now. Do we have our chairpersons with us, Dr. Hiralal? Because I could see Krishnendu sir and Vidya to be madam, but did we have Hiralal sir?
I think Dr.
I was
Krishnendu has
trying
to
to
go early. Dr. Krishnendu, you want to go early?
Yeah, actually, thank
Yeah.
you, Lakshmi.
Yeah,
For
yeah.
Let
So
this
it will be
Krishnendu
with
do
the
first hour. Yeah.
Yeah, it will be now with Krishnendu. So Krishnendu sir, and so like for our chairperson, so does this remains the same. I mean, yesterday is how we had taken it up. As every faculty will get 18 minutes where the timer will start. And we have three eminent chairpersons today with us. One is Dr. Hiralal Kunar, who has yet not joined, I suppose, with some this thing. But anyway,
No, he has joined.
He has joined.
I'm joined. He is there.
because I'm not able to see him. I
Yeah,
don't know why.
because but he's here.
Yeah. So, okay, so that's excellent that we do have with us Dr. Hiralal Kunar sir, who is a
Yes,
professor
I'm
in
there.
Department of
Welcome.
OBGYN, KPC Medical College and Hospital, Kolkata. Then we have with us another very eminent professor, Krishnendu Gupta sir, who doesn't know sir. He has been the professor, he is the professor and unit head of Department of OBGYN, Vivekananda Institute of Medical Science, Kolkata till date. He has been the chair of Indian College of Obstetric and Gynecologist, ICOG 2016. We also had a lot of programs and a lot of academic events during that 2016. I remember very well. Then also sir has been the International Lead Fellow for MRCP Part 2, Royal College of Physicians of Ireland, and examiner till date. He has got lots of, he has held several key posts you can see. And also he is the, for AOFOG, he is the representative from India, FOGSI representative to AOFOG 2020 to 2024. Welcome, sir. We have with us Professor
Thank you very
Dr.
much.
Vidya Thubi, who is a professor and head of Department of OBGYN at Elimination Medical College, Vijaypur. She's been the Kasoga president. Now she has taken up the presidentship of Kasoga, and she was the chairperson of Food, Drugs and Medical Surgical Equipment Committee 2018 to 2020. I remember she had also received the Best Committee Award for her excellent work during her tenure as chairperson. So now what we do is we do have these, the eminent chairpersons. We have 9 topics today. Each chairperson gets 3 topics to chair. And after each topic, after the 3 collective topics, there will be the review and their inputs and their expert opinions on the 3 topics for which they have chaired. So now, Krishnendu sir, do you have to go early? So do I have to keep you first? I mean, I'm asking you.
Yes.
I had actually requested for that because I do have a
Yeah.
program.
Dr. Krishnendu, yeah.
Okay, so now the first, so now we go ahead and Krishnendu sir will be chairing the first 3 talks. So now the first talk is about, now we are talking so much about HPV, isn't it? Since yesterday, a lot of HPV. Now we really want to know what HPV is as a primary screening, and we do have an eminent speaker with us, Dr. Lata Subramaniam. She is a consultant gynecological oncology, G. Kuppuswamy Naidu Memorial Hospital, Coimbatore, and she is affiliated with secretary. She's doing an excellent work as a secretary of AOGN India. And over to you, Dr. Lata, for your talk. You can share your screen now. Is that Dr. Lata over here?
Yeah,
Dr. Lata, I can't see you.
I'm searching her only.
She's there.
Ma'am, she is there.
Yeah. Please share your screen.
While she's sharing her screen, can I just thank
Yes, please, sir.
Dr. Lakshmi
Please go ahead, sir.
Srikhande for this wonderful initiative as the ICOG chair. She's doing fantastic work. And what to say about you, Priya? You've really taken the oncology committee by storm and following Bhagya Lakshmi's great footsteps. And I think hearty congratulations to the entire team. This is what ICOG is all about. And I
Yes.
think sharing knowledge, dispersing knowledge, disseminating knowledge And then what I loved was the pre-test and the post-test. And I think that will keep everyone busy. Hearty congratulations to all of you, really. God
Thank
bless
you.
you all.
Thank you so much.
Thank you very much, sir.
Well done, Lakshmi.
Can we have Dr. Lata Subramaniam? Can't see her in the...
Yeah, Jignesh.
Hello.
Ma'am, she has logged in.
Yeah, Dr. Lata. Yeah, we are waiting for you.
Yeah. So let me just share my screen.
Please, yeah.
Yeah, please share your screen, and Jignesh, the timer should be on from your end.
Let her first share her screen. Yeah.
Yeah. After she starts, you please start the timer, not before that.
So
Is there any problem?
There's some problem or glitches, Lata?
yeah, I'm just not able to share it. So do you want to go to the second presentation, and I'll sort my.
I think
That will be
let's
better.
move forward to the second one, then we can save some
Yeah,
time.
just introduce the second
Now,
speaker.
Dr. Asha also, I am not able to see. Can you, Dr. Asha Jain, have you logged in? Because the second topic is Bethesda Revisited.
Ma'am, she is there.
Dr. Asha?
Please, yeah. Asha, please share your screen.
Oh, I'm there. I'm there.
Please.
Dr. Asha, will you take it up? Will you take it up as a first talk? Are you ready?
Just a second.
Doesn't matter. Take your time. And third is with Dr. Mala Srivastava. So all of you be prepared.
Okay.
So sorry, dear friends. I'm seeing a lot of requests about sharing the pre-test link. Don't worry at all. Don't bother yourself. Kindly concentrate on the topic, because then post-test, we're going to have the same thing, you know. Don't worry at all. It's not an exam.
That was only,
Self-assessment.
it was open for only 10 minutes and now the link is closed. That is why you are not able to submit. Now you are not able to open the link. So please don't bother to do anything with that link.
Yeah, please concentrate here. And now Dr. Asha has started with Bethesda Revisited. Over to you, Asha.
First, light on. Thank you, Priya. Thanks a lot for having me here. Thank you, Dr. Lakshmi, for this opportunity. And I hope I'm able to do justice to the topic.
Just make it slideshow.
I have 20 minutes, right?
You have 18 minutes.
Time. Yeah.
Asha, can you make it into a full screen, please? Slideshow.
Yeah, I will do that.
And welcome.
Thank you. So, there. So my topic today is Bethesda Revisited. So I start with a quote from Mark Twain. He has said, "The reports of my demise have been greatly exaggerated." All of us who have now shifted to HPV as the primary mode of testing are actually thinking that a smear is no use, it shouldn't be done. But now let us talk about why it is not dead, it's very much alive. The Bethesda system came up in December 88 in Bethesda, Maryland, USA, when a few doctors sat together and decided that they needed standardization. What was the principle? The principle was that the terminology must communicate clinically relevant information from the lab to the patient's healthcare provider. The terminology should be uniform and reasonably reproducible across different pathologists and labs. And it should also be flexible enough to be adapted in a wide variety of lab settings and geographic locations. And also, the terminology must reflect the most current understanding of cervical neoplasia. So what they are saying is they have a very dynamic system that standardizes the terminology between two pathologists and clinician. Now there is a two-tier reporting system for squamous intraepithelial neoplasia. It is a low-grade lesion or a high-grade lesion, L cell or H cell. Previously the CIN 1, 2, 3, all that has disappeared and it's now just 2. In 1994 came the first atlas of the Bethesda system. The first update to the Bethesda system came in 91, where they added the criteria for interpretation, they added diagnostic terms, and they also added a term, the adequacy of the specimen. In 2001, the TBS terminology was defined and a website was made which had a dynamic self-test. Now, what is the effect of the changes made in 2001? There was initiation of research and clinical trials. There was alignment of management with terminology, and the Bethesda system as a prototype for standardized reporting terminology in pathology. So it means it didn't work only for the pap smear, but for a lot of other things that you can use the same terminology. You have to standardize terminology. The effect was that the implementation of the Bethesda system initiated several downstream events that significantly influenced cervical cancer screening and management, and also impacted terminology development for other areas in cytopathology and histopathology. There was a study, the Bethesda Inter-Observer Reproducibility Study, the BURST 1. Then, after 2001, there was another Bethesda meeting in 2014. Now, why? Why the change in 2014? Because high-risk HPV testing had come up, genotyping had been incorporated in screening, primary HPV testing had been started, HPV vaccination was also started in 2006. So cytology thus became a triage or reflex method. It did not remain the primary method of screening. The other changes were that it was now mandatory to report benign appearing endometrial cells if they are seen in women more than 45 years. If there are LCIL and a few cells that would show concurrent HCIL, a new category was not created. You have to report the higher lesion. You have new guidelines and also the third edition of the TBS system Atlas. This is how the Atlas looks like. It is freely available on the net, free of cost. And it teaches you a lot of things. You can look at it. There are tests. You can share your images. You can self-test yourself. And you can also understand what the pathology actually means. The terms included are the adequacy. It is a non-neoplastic lesion. If endometrial cells are there, they are reported beyond 45. Then ascus H, squamous epithelial abnormalities which are glandular in character. If you see any other malignant neoplasm, if there is anal cytology, or if you recommend any adjunctive testing, all this is included in the Bethesda System Atlas, and I would recommend everyone to at least skim through it so that you would actually understand the Bethesda system better. So this is the detail of it. The whole Bethesda system is here, again taken from the Atlas, and you can see it has the specimen type, the specimen adequacy, general categorization, then interpretation of the result. The main thing is negative for intraepithelial lesion or malignancy. This is the major reporting. If you remember, in the days of CIN, most of them used to be reported like SIN1 or inflammatory. Now, what you write is mostly NILM. Then epithelial cell abnormalities, squamous cell or glandular cells. So this I've already explained in the diagram. It also has a computer-assisted interpretation, and there are educational notes and comments. So the use of written recommendations or comments in cervical cytology reports is optional, and when included in the cytology report, they must be worded carefully and relay clear, concise, current, evidence-based information. In the second edition of the Bethesda Atlas, it was recommended that such comments be directed to the clinician and that the lab not communicate directly to the patient unless specifically instructed to do so. So the comments are directed to the clinician. In 2014, they added a risk assessment. This new chapter is an important addition to the third atlas because it is a key to understanding how the results of various screening and triage test combinations relate to the patient's risk for cervical cancer. This is the endpoint. The concept of equal management for equal risk, along with balancing benefit and harm of screening, formed the basis of the 2012 management guidelines for abnormal cervical cancer screening tests and cancer precursors. Then came in 2014 the BURST 2 study, which is still ongoing. The web atlas is introduced free of cost, and now as gynecologists we see how it relates to what we are doing. We relate it to the FOGSI GCPR, which has taken a lot of help from the WHO manual. FOGSI GCPR screening and management of pre-invasive lesions of cervix and HPV vaccination. This is the Bethesda system. In very short, the abbreviation CIN is cervical intraepithelial neoplasia, ECC is endocervical curettage, HPV, human papillomavirus, LEAP is loop electrosurgical excision procedure, TZ is the transformation zone, and VIA is visual inspection with acetic acid. We have these categories: NILM, ASCUS, ASCUS-H, LCIL, HCIL, and SCC. And in glandular, we have the comparative AGC, AGC-FN, which favors neoplastic. Then in situ carcinoma, endometrial cells in a woman who's more than 40, adenocarcinoma, or anything else that you see. Now what are you going to do? When you have tested with HPV and cytology in a woman who is more than 30 years of age, then what are you going to do? This is the part that we are more worried about. So HPV is negative, cytology is negative, screen once in 5 years. HPV is negative, but cytology is positive. Here we have to understand that HPV has less specificity, but cytology has more specificity. So you have to take this patient forward and either, if it is ASCAR or LCIL, you have to repeat co-testing at 1 year. But if it is ASCUS-H or HCIL, then you proceed directly to colposcopy and biopsy and then follow the management guidelines. After co-testing, if it is again HPV negative and cytology negative, return to the routine. If it is positive, HPV positive, or cytology is more than ASCUS, proceed to colposcopy and then follow the treatment guidelines. If she is HPV positive but cytology negative, then you would repeat the co-testing at 1 year. If resources permit, you can proceed and do a genotyping. If it is 16-18, then go ahead and do a colposcopy and biopsy. If it is other HR, then you repeat co-testing at 1 year. So basically, all these charts tell you one thing, that if anything is positive, if it appears benign, you can wait a year. If it appears that it's going to progress or it is a high-risk lesion, proceed for a colposcopy and then follow the treatment guidelines. If she is both HPV positive and cytology positive, directly go for a colposcopy and biopsy. So can you see, in all three, that is the one thing that remains common. Now if the diagnosis is ASCUS, she has been screened only with cytology and her diagnosis is ASCUS. What are you going to do? If she can afford it, or you can convince her, do an HPV test. If it is negative, test at 5 years. If it is positive, go ahead and do a colposcopy and biopsy. Or if it is a low risk, you can go ahead and do a cytology at 1 year. Now there is one other category, that the patient is non-compliant. You don't know if you are ever going to see her again. Then go ahead and do a colposcopy or a VIA and biopsy and actually give her the treatment, because you cannot afford to lose a patient. At 1 year, if it is negative, then you return to cytology screening in 3 years. If it is LCIL or ASCUS, again after 1 year, then again proceed to colposcopy and biopsy. If it is ASCUS-H or HCIL, then go ahead, do a colposcopy and follow the treatment guidelines. Then we come to screening with cytology, and the diagnosis is LCIL, woman is above 30 years of age. Again, HPV test is, do a HPV test. Positive, go for colposcopy biopsy. Negative, co-testing at 1 year. And the same chart follows. If she cannot afford an HPV test, go ahead and do a colposcopy and take a biopsy if needed. Follow the treatment. If she is non-compliant, directly go for a colposcopy and require treatment. If she is less than 30, what are you going to do? She has ascus or LCIL and she is less than 30, then you would repeat the cytology annually twice. That means every 6 months you would do a pap smear. If it is normal, repeat at 3 years. If it comes positive for ascus, go ahead and do a colposcopy and biopsy. If it's normal, then you repeat the cytology at 1 year. But if it's abnormal, then you follow the treatment guidelines. Again, non-compliant patient, proceed with colposcopy, VIA and biopsy. Just because she is under 30, we should not think that she will not get cancer, because as you remember, the very famous artist who actually died when she was 29. She was diagnosed having cancer at 27. Screening with cytology, management of ascus H or HCIL in a woman who's more than 30. If it is HCIL, then you have no other option. You would do a colposcopy with cervical biopsy and endocervical assessment. If colposcopy is adequate, the entire transformation zone is seen and she is less than or equal to a low-grade lesion, SIN 1, then you would co-test at 1 year, or you could just ablate and then follow up annually after 1 year till she comes back to normal. If it is a high-grade lesion, in that case, you are going to proceed and do a LEEP or an ablation of the transformation zone. This is in case it is a completely visible type 1 or type 2 transformation zone. If it is an inadequate or a type 3 transformation zone, then you need to do an excision procedure like a conization, and then according to the biopsy, you have to proceed and do the further treatment. This is the eligibility. I'm sure there's a lecture on that, so I will not be taking that. If you have ascus H or HCIL in a woman who desires a pregnancy, you would do a colposcopy. If there is no SIN 2 or 3, then repeat the cytology and colposcopy. No high-grade abnormality in cytology and colposcopy, you can return to age-specific routine screening. But in case you get a high-grade lesion, then you're going to follow the treatment protocol. Cervical biopsy, follow-up, and diagnostic and curative excisional procedures. Also, you could thermoablate if it is a completely visible lesion. If it is not, then ablation is not a criteria. What happens when you have abnormal glandular cells or atypical endometrial cells? If it is endometrial cells, then you would go ahead and look for endometrial pathology and manage accordingly. But if there is no endometrial pathology, then colposcopy and biopsy is done. If it's normal, then age-specific screening. If it is abnormal, then follow the FOGSI GCPR for treatment. In pap smear, if you have abnormal glandular cells or suggestive of malignancy, atypical endocervical cells, again you would go for colposcopy plus minus biopsy, endometrial sampling and endocervical sampling. And then the treatment will depend on what you find, whether you have an LCIL or an HCIL, and if you have an endocervical lesion, what is the extent. But here you go ahead with a colposcopy initially. Follow up with HPV is also a very good idea. If you have abnormal glandular cells or carcinoma in situ, what are you going to do? AGC, colposcopy, endocervical sampling, endometrial sampling. If there is endometrial pathology, go for a hysterectomy, and according to the stage of the endometrial cancer, you would choose your hysterectomy. If it is colposcopy, endometrial sampling is done and you find endocervical pathology, then you can go ahead and do a conization. you need an intact specimen with non-fragmented margins. Now, a hysterectomy is also an option in glandular disease when you have a high grade lesion, because you cannot see the complete extent of it, and it will depend on the type of hysterectomy would depend on the extent of the disease. You've done a colposcopy and endocervical sampling and endometrial sampling, and they are all negative. Then proceed for evaluating the ovary and the tube by imaging. And if there is no pathology detected, you would still go ahead and do a conization, because, as I said, a smear is more specific, though it is less sensitive. So we do not want to miss anything. Now you have another thing, that is the unsatisfactory smear. If it is unsatisfactory, then you review the report. If possible, go ahead and do an HPV test. HPV is done. If it is negative, don't worry. If it is positive, then follow the screening GCPR. If HPV test is not available, she is less than 30 years, we know we do HPV test only beyond 30 years of age, then repeat the cytology in 2 to 4 months. Again unsatisfactory, go ahead for a colposcopy. Ask us, follow the guidelines. NILM, return to routine screening. If it is VI unsatisfactory, you don't have an HPV, she is less than 30, then you can directly go ahead and do a VIA. If it is negative, return to routine screening. If it is positive, then you follow the guidelines. One thing is, a VIA is only effective if you have a transformation zone that is completely visible. If it is not completely visible, then VIA doesn't work. So in conclusion, when we say cytology versus HPV, it's not versus HPV, they are complementary. Cytology has decreased sensitivity compared to HPV in screening, but cytology has increased specificity compared to HPV in screening. The use of cytology as a triage pool after a positive HPV test is required. Wherever HPV is not available or not reimbursable, cytology remains the screening tool. Treatment and follow-up as per guidelines has to be ensured after a positive test, and cytology must be from a standard lab with standard reporting protocol as per revised Bethesda protocol. So I end where I started. The reports of my demise have been greatly exaggerated. I am there to be there forever to help you in preventing women from cancer. Thank you.
Excellent. Dr. Asha.
Well done,
So-
Asha. That was a wonderful presentation. And we are really running short of time, so I'll hand over the proceedings again back to Dr. Priya.
So Dr. Lata Subramaniam, have you sorted out? You're able to share. So talking about Lata, quickly, I'll just introduce her to you all. I think I have introduced her.
Dr. Priya, I'm sorry, I've just sent my presentation to the team. I'm not sure whether they are able to share.
All right.
Ma'am,
So
we won't be able to share it because it is a MacBook file, presentation file, Mac presentation file. We won't be able to share it.
Okay, fine. All right.
will you be able to do it, Dr. Lata?
Let me just
Shall
try.
I stop sharing my screen so that you can
Yes,
share it?
yeah,
Yours,
yeah, I'll just try from here.
right? Yeah.
Dr. Lata, if you can send it to me, I am running this program on a Mac, so I can run it for you.
Yeah, can you please tell me your email?
You put it up on the chat box,
Asha@drasha.in. I'll put it in chat, Dr. Lata. Just a minute.
Okay, fine. Yeah.
So in the meantime, Dr. Mala, can we take up with you?
Yeah, I'm ready.
Are you ready?
Yes.
All right. So here you go. Yeah, just a minute. I will formally introduce you as the speaker because we have been seeing you since yesterday. You're not new at all. You're the co-convener of this whole program series. So she is head of the Gynae Oncology Unit at Sir Gangaram Hospital, New Delhi. And she's a senior consultant and professor, gynae endoscopic and robotic surgeon with a vast years of experience and lot of awards to her credit. We would like to hear from Dr. Mala regarding the tissue biology of CIN.
Can you see
Make
my
it full screen? Yeah. Can you make it full screen?
Yeah, I'm trying to make it full screen. Good evening, everyone. I must congratulate Dr. Priya to having formulated such an excellent program. And the topic given to me is tissue biology of CIN. We all know cervical cancer is the fourth most common cancer among women worldwide, with an estimated 5,70,000 cases and 3,11,000 deaths in 2018. And 85% of worldwide deaths from cervical cancer occur in low and middle income countries, where the death rate is 18 times higher than the developed countries. The development of molecular biological techniques, genetics, epigenetics, as well as immunological aspects have resulted in the understanding of the etiological role of HPV infection in the oncogenesis and tissue biology of cervical cancer. We know the peak age of HPV infection is 20 to 29 years. No difference in acquisition of HPV for virgins and non-virgins. HPV infection produces an immunity that is type specific. So CIN is a pre-malignant squamous lesion of the uterine cervix, we all know, and Dr. Asha has nicely told about the Bethesda system. I just want to show this slide to correlate the last system, Bethesda system, and previous terminology. Here we want to just add that CIN is a histopathological diagnosis where cytology is LCIL or HCIL. But if CIN2, if it is P16 positive, it is classified as HCIL, and CIN2 that is P16 negative is classified as LCIL. So we all know about CIN1, 2, 3, and how do they progress. Initially, there is virus production. Later on, it is viral integration and then progression into micro-invasive carcinomas. The cells in a nutshell, normal cervical cells look like this, and then you see CIN, how the CIN2 and CIN3, how the nucleocytoplasmic ratios are changing. So we see all these changes and all the photographs you can see, 1/3, 2/3, and whole CIN3, how it is converted. So the concept that most of the transforming CIN and cervical cancer arise from the exposure of the squamo-columnar junction cells to high-risk HPV virus, which suggests a high susceptibility of these cells to HPV transformation. There has to be a breach in the epithelium. Then and then only the HPV virus can infect the basal layer. And from there, it starts its infection and all the progression of the disease. So initially, there is a productive CIN. Later on, it is transforming CIN, and which progresses. If the virus infection is persisting for 10 to 20 years, then and then only it is converted into cervical cancer. So we know this squamo-columnar junction is a dynamic area. It shifts its location through age, from being external to internal. So we all know how the transformation zone changes in different phases of a human's life or female's life. So it is also known, transformation zone is also known as the ectropion, an area where original squamo-columnar junction and new squamo-columnar junction occurs due to regenerative metaplastic responses. The process of carcinogenesis starts as a transformation zone. There are two mechanisms involved: squamous metaplasia of the subcolumnar reserve cells and squamous epidermidization. The metaplastic process is very active at menarche and during and after the first pregnancies, because these are the periods of high estrogenic activity and low vaginal pH. Metaplasia originates at squamo-columnar junction, and it also replaces the columnar epithelium. So this is how you see. If there is a normal metaplasia, physiological metaplasia, and the host immune defense is good, then it culminates into well-differentiated squamous epithelium. But if the metaplasia doesn't occur properly and it is the area is infected with HPV infection, host immune defense is less, then it progresses to atypical metaplasia, then CIN, CIS, and invasive carcinoma. In most cases, we know that anterior lip of the cervix is twice likely to be develop CIN than the posterior lip. Rarely CIN originates at the lateral angles. Once overt, it can progress horizontally to involve the entire transformation zone. And we have to understand there is a single focus in the transformation zone where the CIN begins, and then later on it advances. Once the metaplasia matures, then it is known as healed transformation zone, and then it cannot be infected to oncogenic stimuli. CIN, as we know, is most likely to develop among young adults, among the early 20s or after pregnancy when metaplasia is very active. After menopause, there is a very little chance of metaplasia remaining and be infected with de novo HPV. If the menopausal woman is having infections, that means having lesions, that means the infection has been persisted for a long time, for last 20 or 30 years. So what are the key factors in initiation of cervical cancer? Progression of HPV-infected epithelial cells. These alterations involve epigenetic and genetic factors, tumor suppressor genes, and first of all, the virus has to be integrated into the host cells. That is the most important thing. This is the HPV virus. There are two types, cutaneous types or mucosal trophic types. They are the viral proteins. E1, which is viral DNA replication and transcription. E2, viral DNA replication, apoptosis, transcription repressor of E6, E7. E4, viral DNA replication. E5, immune recognition. E6, it depresses P53. E7, it causes degradation of retinoblastoma. And of course, L1, L2, which are the major viral capsid proteins. So these cutaneous HPV are beta genus, mucosal HPV are alpha genus. So genetically, they are different. They have this open reading frames. These frames are capable of going into the host cells and causing encoding for new proteins. That is how they change the nature of the host cell DNA. As we can see, L1, L2, they cause release of the viral particles. And there is E5, it releases superficial cells laden with mature virus. And whereas E6 and E7 are the major trigger oncogenetics. As I told, E6 suppresses P53 protein and E7 suppresses retinoblastoma protein. P53 induces cell growth arrest at G1 phase. So if a cell is infected or damaged, suppose a host cell has infection with HPV, it is a damaged cells. So it should undergo cell death. But if P53 is suppressed, then these cells become immortal. Now, retinoblastoma protein, it does not allow the infected cells to divide. But if retinoblastoma protein is suppressed by E7, then these damaged cells go on dividing and producing similar cells. That is how E6 and E7, they are oncoproteins and they allow the growth of the defected or infected host cells. And that is how the HPV causes oncogenesis in the local area. See, this is how E6, E7 works. If there is a infected cells, then toll-like receptors, they activate nuclear factor kappa, interferon, regulatory factor, MHC, MHC2, and that is how they limit the infection. But if TLR is suppressed by E6, E7, then all these actions is not going on and the infection persists and it progresses. Similarly, in here we see MHC2 that causes the antigen presenting cells, which activates all the cytokines, pro-inflammatory as well as anti-inflammatory, to remove the infection from the cells. That is the normal immunological mechanism. But if the normal mechanism is suppressed by HPV, E6, E7 proteins, then this normal mechanism of self-defense is not going on, and the infected cells, they go on multiplying and producing the persistent infection and causing CIN1, CIN2, CIN3 changes, and ultimately microinvasive cancer. See, here also we see that HPV E6, E7, they act through the multiple cytokines, which causes pro-inflammatory reactions and suppresses anti-inflammatory reactions. As a result, the infected latent protein cells, they persist in the system. So high risk HPV E5 is also considered to be tumorogenic and enhances the immortalization potential of E6 and E7. This is how you see, if any infection is coming, RB and P53 will suppress them. As a result, that they cannot reach the nucleus. But if the effect of P53 and RB is suppressed, then this infection reaches the nucleus, and the DNA of the HPV is incorporated into the DNA of the host cells. Now the nature of the host cell has been changed, and now this particular altered host cell will go on producing like host cells. As a result, you find that the basal cells are now producing different or defective type of the cells, which is causing CIN1 changes. Then if the infection persists or the process persists, then it causes CIN2 changes, and then it causes CIN3 changes. That is how the carcinogenesis of this at the level of the cervix goes on. This representation is also seen that P53 actually causes angiogenesis, growth arrest, DNA repair, apoptosis. But if the action of P53 is suppressed, then the defective cells go on into the cell cycle and keep on multiplying, and they do not undergo apoptosis. So how does a progression occurs? Carcinogenesis is a process by which normal cells becomes abnormal and transfer into cancer cells. Oncogenesis only occurs as a result of prolific genomic and epigenomic alterations in these cells. And we know, and we have seen how E6 and E7 play a major role in the alteration of the host cellular function. We see then there is so many kind of genes which are upregulated and downregulated. So as a result, the cell proliferation genes are highly upregulated in CIN2 and 3 when compared to a normal cervix. We see those so many kind of genes which are upregulated. Most studies shows that P16 is also known as CDK9N24, and it is seen that it is a potential biomarker in cervical cancer. Angiogenesis also occurs in the precancer stage as an indication of development into the cancer. MCM is also highly upregulated in cervical cancer and is being investigated as a biomarker for the screening of cervical lesion. These are the actually genes which include mini chromosomal maintenance proteins MCM2, MCM4, MCM5, MCM6, MCM10, and these are important proteins in replication initiation and allow for DNA polymerase to initiate DNA replication. Furthermore, to accomplish cell proliferation activity, the genes involved in mitosis also play a significant role. And these are the different genes, TPX2, CHEK1, CDK1, all these are genes that are promoting mitosis of the defective cells. And what are the immunological factors? Type 1 cytokines, interleukin, leukin 2, interferon gamma are immunostimulatory and thus capable of limiting tumor growth. And type 2 cytokines, IL-4, IL-10 are immunoinhibitory and thus capable of stimulating tumor growth. Certain HLA genotypes have also been associated with increased risk of cervical neoplasia. So there are also chromosomal aberration. E6, E7 affect the control of cell cycle and mitotic spindle formation. It induces chromosomal instability, telomerase activation, and eventually cell immortalization. So the defective cells, they are immortal, they do not die, and they also keep on multiplying. Mutational inactivation or loss of tumor suppressor genes, activation and amplifications of oncogenes occur. These are the infections which persist and which also help in progression of the disease. These are the useful molecular biomarkers we all know which are used for the screening and diagnosis of cervical cancer, and it has been used in different stages and different laboratories. So to conclude, HPV infection plays a major role in cervical carcinogenesis. Overexpression of E6, E7 oncoprotein is the key factor that affects tumor suppressor genes, mainly those regulating the cell cycle, and then alters many downstream pathways leading to cancer progression. We have to understand the key molecular mechanisms which is perturbed in the progression from HPV infected cells to CIN and finally to invasive cancer provides an insight into the multitude of pathways involved and inspires the future development of targeted therapies. See, we have to understand over the last decade, there has been tremendous advances has made in our understanding of the molecular biology of cervical cancer. We are also beginning to understand how interaction between cellular growth, regulatory protein, derived oncoproteins result in uncontrolled cell proliferation. Identification and characterization of specific genetic alteration in cervical cancer has also begun. The rapid advances in molecular biology techniques will lead to a greater understanding of the molecular pathogenesis of cervical lesion and implementation of techniques in clinical practice. So the infection which HPV is the key and nodal factor, and the infection enters through the abrasion in the cervical epithelium. It reaches the basal epithelium, infects the cells, integrates into the host cells, and then starts producing the defected cells. It also suppresses P53 and retinoblastoma protein. As a result, these infected cells become immortal and they go on multiplying, and the causes cells of the each type. So the take-home message is 80 to 90% of population will have an HPV infection at some point in their reproductive lives. For most, HPV is a transit infection that will clear over in an average of 2 to 3 years. High-risk HPV are associated with lower genital tract cancers, and it is the E6 and E7 oncoproteins which are causing host cell integration, persistent of the changes which causes CIN to progress to the invasive cancer. It is not only the infection, it is the genetic, immunological capability of the person which can restrict the infection or which can allow the infection to progress. Thank you for your patient listening.
Excellent, Dr. Mala, and right dot on time. Thank you very much. This is
Excellent
appreciable.
presentation, Dr. Mala. Lovely. Very lucid.
Very lucid as well. And now we go to, I think, yeah, Lata, you can take it up from there. Thank you.
Thank you very much. And thank you, Dr. Asha, for making this possible. So we will then, for the next few minutes, I will be speaking on primary HPV testing and why this is important. If I can have the next slide, please. Can I have the next slide? Thank you. So we've spoken about Viability, we've spoken at length about
I
cytology.
cannot make it full screen. It's not running on full screen. Okay. Is this
Yeah, this
visible
is
enough for you?
absolutely fine. Yeah, this is absolutely fine.
Okay. Thank you.
So we've spoken about Viability, about importance of cytology and co-testing. And as per our GCPR, we have the recommendation of low resource settings and high resource settings. Previously, the standard of care was always the pap smear, but we know that the pap smear has very low sensitivity. It only becomes good because by repeated testing, the test itself gains more sensitivity. It is very specific. Basically means to say if the pap is negative, then the chances are that this lady harbors pre-invasive cancer is going to be very, very less. And whereas if you can see the sensitivity of the HPV DNA test, it's very, very high. And that is what we want for a screening test. We want a screening test not to miss out any woman who has a possible HPV infection, maybe leading on to cervical cancer. So that is one important thing that all of us have to keep in mind. Yes, why is it that you want to think about going from a pap smear, which is something that all of us are used to an HPV testing? Now, when we did the conventional pap smear, we had a lot of unsatisfactory smears. And for us, getting women to follow up is always a problem. Use of the liquid-based cytology reduced the number of unsatisfactory smears. These are basically smears that the cytotechnician is not able to read, and the woman has to come back for a repeat test. That came down to 2%, which was very, very good. But it does add on to the cost. And one thing that all of us have to remember is that it did not improve the detection of high-grade smears. Next slide, please. So why is HPV testing good? One, it is objective. It is reproducible and robust. Very, very important, it has a built-in quality control. When anybody does reading of a pap smear, be it a cytotechnician or a pathologist, generally in any pathology lab, you will find that 10% of all negative pap smears have to be rerun. This is an inbuilt quality control to make sure that we don't miss out, we don't have any false negative tests. Whereas when you come to HPV, there is no human interface. You just put it in the machine, it comes out, and you have a printed report. And that basically makes it more reproducible and robust. It does have an inbuilt quality control. There can be rapid turnaround of tests, and that becomes very, very important. And a large number of tests can be done in a day. And more importantly than all of this, at least in my particular purview, I feel that HPV is so very important because we can do self-sampling. And I will be speaking about that a little more along in my presentation. Next slide, please. So as I did mention, primary screening in the community, in a healthcare facility can be done either as a healthcare collected sample or a self-sampling. That is when you want to diagnose women to see if they are HPV positive or not. It can be done as a test of cure. And this is when women have undergone treatment and you want to know if your treatment has cured the women of the infection and, of course, the pre-invasive cancer. And it can be done as co-testing when it is done along with the pap smear, though the WHO recommendation at present do not really encourage co-testing because of the cost involved. Now, this is a relative sensitivity and the specificity of high-risk HPV compared to cytology for detection of CIN2. And if you can see on the left, you find that the HPV is definitely better than the pap smear. And this is something that we have to keep in mind because it is based on all this evidence that recommendations come forth. Next slide, please. Very interestingly, these were randomized controlled trials which looked at comparing HPV-based screening versus cytology screening. And you look at the risk of CIN2 and 3 in the first and second rounds. When you look at the upper two graphs, you can find that the HPV screening picks up more number of women who have high-risk who have CIN2 and 3. And if you come to the second round, you find that because the HPV arm has done so well, the numbers that are picked up of high.
Sorry to interrupt, Lata, but the slides are not in full screen. There's a request from the audience that it may be went into a full screen, please.
I
Jignesh?
think there was a glitch, Charmila. So I think Dr. Asha is helping me play the screens. I've sent it to her. So she said that
Asha can rectify that. Asha?
she said she was not able to.
Okay, okay. So we'll just inform the
Dr.
audience. that
Charmila, when I make it full screen,
yeah.
it actually doesn't move. That is the
Okay,
whole
okay.
problem.
Okay, I hope the audience understand. No problem. Please continue.
Thank you.
It is running full screen, but with the sidebar on.
True.
That we can see. That sidebar also, they are feeling uncomfortable, I believe.
Yeah, but actually, if I put that off, the slides don't move at all.
No problem. Please continue. It's not an issue. We'll tell the audience.
Armila, this is the best which Asha can do. I think they have to cooperate.
Okay, sir.
I think she's doing a grand job. Let her, this is the best
Thank
that it can be.
Okay,
done.
sir. Thank you.
So in the second round of screening, we find that because the first round was so very effective, you know, the numbers of CIN 2 and 3 that are picked up in the second round is generally less. So this again shows that HPV would perhaps be even a better mode of screening rather than go on to cytology. Next slide, please. Next slide. So as I did mention, I will speak a little bit more. I think the evidence is very, very clear. The WHO has put forward guidelines that if resources are available, HPV testing would be the test of choice. In fact, based on the call for cervical elimination, 90% of women have to be tested using a high precision test, and we are talking about HPV. And WHO has even mentioned that even if you can test a woman twice in their lifetime at 35 years and 45 years, this would be more than adequate. Yes, it is a little bit more expensive than cytology. And how do we offset that? Remember, a pap smear can be done or should be done every 3 years. An HPV test, if it is negative, can be done every 5 years. So that is how the cost effectiveness works. So though the HPV test is slightly more expensive, because you can increase the intervals of screening, I think the cost, it does become more cost effective. And very, very importantly, this is the only way we can do self-sampling. And the next few slides will be on self-sampling. Next one, please. So we know that there are barriers to screening. All of us have worked in the community for screening, and we find that even though screening is offered free of cost, women do not participate very comfortably in screening programs. And this is particularly low amongst certain ethnic and socioeconomic groups, and this includes the low income groups. So these are barriers to screening that all of us are very aware of. Next slide, please. So what is it that women feel when we invite them for a cervical cancer screening program? They have feelings of embarrassment and shame. They do not want a physician to see or touch their genital area. They are worried that it will be painful, and there is an absolute lack of understanding about the importance of HPV and cervical cancer screening. And when we did a cross-sectional questionnaire survey, we found that the awareness in and around Coimbatore was only about 16%. So which shows the amount of work that needs to be done to increase awareness in this particular area. Next slide, please. So these are some things that we have to keep in consideration when we offer cervical cancer screening to women. And HPV testing may be a way forward. Next slide. So this is generally what is used. We tell them that the swab can be introduced into the vagina. Previously, there was a suggestion that there may be a 10% discrepancy between results, between the pickup of high-grade CIN, if between a healthcare worker collected sample versus a self-sampling. But now the evidence is clear that it is almost on par, and a vaginal sample is more than adequate. Next slide, please. So self-sampling will definitely result in more individuals willing to participate in the cervical cancer screening program, and it removes many of the barriers that prevent women, especially in low risk and low economic and minority groups, from participating in regular screening programs. Next slide, please. And these, if you can look at the forest plot, you can find that when HPV self-sampling is offered, this definitely works to increase the participation in cervical cancer screening programs. Next one. So this is a meta-analysis which looked at the accuracy of HPV testing on self-collected samples. And this is very important. Before we say that, this procedure can be done, we have to make sure that the evidence is good. And you can see that there is a lot of concordance between healthcare worker collected sample and self-sampling. Next one. And when self-sampling is included, there is an absolute increase in the screening coverage, as you can see with the p-values. So I think the evidence is very clear that self-sampling has to be there as part of cervical cancer screening programs. And when you incorporate it, your screening coverage definitely will increase. Next one, please. So this, again, a meta-analysis of about 33 studies, which showed that there was more than 2 times more participation when sampling, when you go to a particular lady to the house, offer her self-sampling and make sure that you collect the sample from her at her doorstep. And I think that is what makes the difference. And if we have to go towards the global elimination of cervical cancer, if this is what works, I think this is what we have to do. Next slide, please. Again, a validated questionnaire. This was work that we have done from our own study. This was a small cohort which we used self-sampling, and we found that 98% of women were comfortable with self-sampling and 99% would recommend it to others. And only about 10 to 11% experienced some sort of pain. And 99% of individuals did prefer self-sampling over physician collected sampling. And this is exactly what women are telling us. Women are telling us that self-sampling removes logistic barriers as well as the physical discomfort of going to a healthcare professional to get a PAP done. And this is not just India, this is global, from Australia, from Mexico. And they felt that this gave them more control over their own health and also was less painful and less embarrassing. Next slide, please. So my opinion is that self-sampling has to be a mandatory tool to achieve our 70% screening coverage by 2030. It is effective. It can be used in different clinical scenarios. It is women-friendly. Women find this more acceptable and will definitely help screening coverage when it comes to global application. I will skip the next few slides. If we can go on to the next slide. Yes. So these are the global-based, that's a real-world-based screening programs. And this shows that many countries will go on to the next one. Yeah. So what happens because of the HPV vaccination programs? What happens to screening in these women? Now, any screening test is only as sensitive as the prevalence. And we hope that once vaccination comes in full swing, the prevalence of HPV infection, the prevalence of CIN1 will fall. And because of this, the pap smear will no longer be a valid screening test to use. Remember, even when starting this, the sensitivity of a pap smear in a single round is only as low as 40 to 50%. So the pap smear will not be of any use of screening in vaccinated cohorts, and HPV testing will have to be the way to go. There are more than enough cost effectiveness study to show that primary HPV screening will definitely be more cost effective. Next one, please. Yes, so what are the harms of HPV testing? Because that is also something that we need to take into account. So there is, of course, a psychosocial impact of screening of a positive HPV test. This is something that we find not just for HPV test, but for any screening test. This is something that we always hear in the community. Women always tell us, I'm fine now, I'm healthy now. You do a test and you tell us that there is a problem. Then what do we do? So let me just cross the bridge when we come to it. So this is something that we also see in our day-to-day practice. So this is something we have to keep in mind. Next slide, please. So screening of women living with HIV, the WHO has put forth very clear guidelines on what needs to be done. It recommends that cervical cancer screening should be started in sexually active women as soon as the HIV infection is confirmed, and they have recommended screening intervals as short as 12 months and not necessarily the 3 years or the 5 years with other screening tests. Next slide, please. What happens in older women? Now, this is something that we have to keep in mind. Remember, Viavilli is not of much use in the older women. This is a major drawback because we are not able to, most of the women that we see have a type 3 transformation zone. We are not able to see up the canal, and Viavilli cannot be used for screening in the older women. Yes, pap smears can be used, and definitely the HPV test can also be used. Next slide, please. I think that really brings to the end of my presentation. Very, very important that all of us participate in some sort of screening program, be it Viavilli, be it pap smear, be it HPV. I don't think it matters what test we use, but it is very important that we use some sort of test so that we get into the habit of screening. Primary HPV screening is recommended only from the age of 30 years. I'm sorry for that. I'm sorry for what is given there. And 30 to 60 years, every 5 years, if you're working in a hospital-based setting, twice in a lifetime, even twice in a lifetime is more than enough. And I think that has to be the way to go. There are many more tests that are coming into the market. There are a couple of Make in India HPV tests, trials of which should be coming out in the next few months. And once we do that, we are looking at two things. One, of course, is the cost effectiveness. If we can bring in a cheap HPV test, that would be good. The second, of course, is the turnaround time, because current HPV tests take a lot of time for the results to come back. Even though we have used Care HPV, and it becomes cumbersome to do a screen and treat visit. And screen and treat has to be the way forward, because you will not get women come back a second time for their treatment. So I feel HPV testing has to be the way forward. Self-sampling has to be important. We need better HPV tests which are more cost effective and which will give us tests in a rapid turnaround time. So thank you very much.
Excellent,
Asha?
Dr. Lata.
Thank
Thank
you.
you very much, Dr. Lata.
Yeah.
Yes, Priya.
And we have to also thank Dr. Asha to be the helping angel hand for making this happen.
Absolutely.
Over to you, Krishnan.
Absolutely. Thank you so much. Thank you.
Well, I think we have had 3 fantastic presentations of HPV as primary screening, as we just now heard. And of course, Asha helped us a lot by chipping in to speak first on the Bethesda, revised classification, or revisited, as very beautifully coined the term, and the true biology, the tissue biology of CIN by Professor Mala Srivastav. So I think we have had a great session. We are running terribly late, and I know how stickler for time our present chair of ICOG is. And before she shuts me up, I think I better keep mum myself. But I'm really grateful to ICOG for doing this. And I think it's extremely important that many such programs by various committees come to the fore, and so that the real knowledge dissemination occurs all over the country, which is actually the primary and sole aim of ICOG. Well done, Priya. And hearty congratulations to you, your entire team, and also to Lakshmi. I don't think there can be much questions or clarifications. That will be all in the post-test. I'm sure the post-test will be a fantastic representation of what these wonderful teachers have taught all of us. And I hand over the mic now back to Lakshmi for her few words, and then to Priya. Thank you very much for the opportunity.
Thank you so much, Krishnendu, for your appreciation. Let's start with the second set of sessions, Priya. Yeah.
Yes, thank you, sir. And so now, after this set, we are now moving ahead, and I'd request Dr. Hiralal sir to be as the chair for this next upcoming sessions. So now we're going to have a sessions on VIA by Dr. Veena Acharya, VILI by Dr. Helen, and IHC tumor markers by Dr. Sarita Shamsundar. So I'm going to introduce the first speaker, Dr. Veena Acharya, who is the senior consultant at the Rajasthan Hospital, Jaipur, and she's been the ex-professor and unit head of Department of OBGYN and Superintendent of Mahila Chikitsalaya, SMS Medical College, Jaipur, MGM College, Jaipur, and of course, she is an asset to my committee. She is a coordinator of West Zone, FOGSI Oncology Committee, and National Executive Member of ISSCP. Over to you, Dr. Veena ji, to take over from here on VIA.
Before that, thank you, Priya, for this nice academic session thanks goes to Chairperson Madam Lakshmi Srikhande and that of the FOGSI, Dr. Rishikesh Pai, and that of the team. Beautiful presentation by the three speakers that they have already spoken. Now the middle part of the session, without wasting much of time, Dr. Veena Acharya talking about the visual inspection of acetic acid. Well,
Can you
madam.
make it full screen, Dr. Veena ji? Can you make it full screen? Dr. Veena, you're muted. Can you unmute?
Yeah. I'll make it full screen, madam.
तो होस्ट नहीं कर रखा।
Is this okay? Am I audible?
Yeah, you are audible.
Okay, thank you so much. Thank you, Dr. Priya and Dr. Lakshmi, for inviting me to today's talk. As you all know, that cervical cancer is the major public health problem. And in India, its disease burden is very high. We lack systematic cervical.
Can you make it full screen, Dr. Veena? Is it possible?
Yeah, this is the full screen, Dr. Priya.
It hasn't been shown here. We are seeing the.
Yes,
problem.
it must be there from.
The problem must be from that side because here it is showing the full screen.
Can you make it, see, this is 60%. If you can even make it 80%, I think it will become more wider.
I send my talk to the Mr. Full screen.
नहीं हो रहा तो छोड़ दो, then you continue, otherwise because timing is
Time
again.
Please continue in that case.
Yeah.
मैं एक दो दोबारा कर दूं उसमें।
Should I explain this again?
Screen is gone, madam.
Just a minute.
Is it all right now?
It is all right.
Better now. It's okay. It's okay.
Yeah, okay. Thank you so much, Dr. Priya and Dr. Lakshmi. As we all know, that cervical cancer is a major public health problem. And in India, its disease burden is very high. We lack systematic cervical screening program in India. There is no doubt that HPV DNA test is a primary screening test. But because of the large population and low resource setting, HPV DNA may not be feasible nationwide at present. Via screening studies in our country have shown the safety, feasibility, and efficiency of conservative treatment of precancerous lesion, as we all know about the Shankar Narayan studies. Moving. No, moving. According to the FOGSI guidelines and recommendation, we all know that there is a clear-cut demarcation about the good resource setting and limited resource setting. And today I am going to discuss about the VIA, which is affordable. And the target age for the VIA test is between 30 to 65 years. As our previous speaker already mentioned, that in postmenopausal women, we are not doing the screening with the VIA test because the transmission zone type 3 is inside the canal. And the age is to start VIA test is 30 years. That should be clear to all the students. And the frequency of the VIA test is every 5 minutes if the test is negative. During my talk, I will just try to describe what is the VIA and how it works, what are the infrastructure and requirements, what test results mean, test performance, strength and limitation of VIA test, program implementation in low resource settings, and secondary trials. VIA test is affordable and appropriate screening method for cervical cancer in India. VIA is a highly sensitive and inexpensive test. One lifetime screening with VIA at 35 years of the age reduce the incidence of cervical cancer by almost 26%. All the speakers have this consensus that we have to do some test for the screening. Government of India has recommended VIA test as a integrated program for screening of cervical cancer at primary health center, because we have the multi-layer health systems in our country, and it is important that we have to do some test at the lower center, then we go to the higher center, CSC, district hospital, then medical college. VIA first reported by the Otvino and Leigh Torrent in 1982. The principle of VIA test is very simple. The abnormal epithelium turns white on application of 3 to 5% acetic acid, because as the dysplastic cells have more chromatin content, the coagulation is intense and cells turn white after the application of acetic acid. And this area seen as acid-white on naked examination, we label as a positive VIA test. The instrument and this requirement for the VIA test are very few. Whatever the instrument we have in our normal gynae OPD are sufficient for the VIA examinations. So we require only examination table, light source, bivalve speculum, cotton swabs, examination gloves, and 3 to 5% acetic acid freshly prepared and saline solution. So we don't require much equipment, much solutions, anything for the VIA test. It's so simple, and in day-to-day practice we can easily do the VIA test. One important thing because in the last talk somebody has asked how to prepare the 5% acetic acid. So every students who are present here, they should, the preparation of, we take the 100 ml of the, want to prepare 5% acetic acid, we have the glycic acetic acid 5 ml. So 5 ml glycic acid and distilled water 95 ml. So preparation to prepare the 100 ml of 5% acetic acid, carefully add 5 ml of the glycic acid into the 95 ml of the distilled water and mix thoroughly. To prepare the lesser amount, we have to 5% acetic acid in the proportion of the glycic acid and the distilled water. Suppose we want to prepare only 20 cc, then we add the 1 cc of the glycic acid with the 19 ml of the distilled water. Same with the 40 ml, we took the 4 ml of the glycic acid and 40 ml. So we can prepare according to that what amount we want, whether we want 100 ml or 20 ml or 4. Because the storage of the VIA, this prepared solution we don't want. Unused acetic acid solution should be discarded. One always remember at the end of the day, only freshly prepared acetic acid to be used every day. If not, because the potency will be reduced and the lesion will be missed. And one important thing, it is that always remember, don't use the without this glycic acids, because it cause the burning of the epithelium. So always be careful about the use the glycic acids. It should always mixed with the distilled water. The method of the VIA test is very simple. What I want to highlight before doing the VIA test, explain to the patients about the VIA test, take the consent. And one important thing I want to highlight, that when we are doing the VIA test, we are also doing the clinical examination. That is one plus point with the VIA test, because in HPV and self clinical test, we are not doing the clinical examination. So inspect the external genitalia for any lesion, do per speculum examination, visualize the cervix, clean any discharge with the saline, apply freshly prepared 3 to 5% acetic acid on the cervix, wait for 1 minute. So solution should be applied completely on the cervix and wait for 1 minute. Then observe the cervix under the good light. Look for the aceto-white lesion and categorize the result of the aceto-white lesions, because it is a subjective thing. So you should carefully watch the what type of the lesion you are seeing, the intensity of the white color of the aceto-white lesion. It is very important whether it is a shiny white, cloudy white, pale white, or dull white. This type lesion you will have to see. Then the border in demarcation of the white lesions, indistinct diffuse margin, or whether it is distinct clear-cut margin or sharp, whether it is raised or flat margin, or whether it is a regular or irregular margin, whether the lesions are uniformly white in color or color intensities varies across the lesions. Then another important thing is the location of the lesion, whether it is near or far away from the transmission zone, or whether touching the scomocolumnar junction. And also note the extent of the lesion into the endocervical canal. Does it occupy the entire part of the transmission zone? Does it involve the entire cervix? Does it enter the endocervical canal? These are the important points. Keep in your mind when you are doing the wire test. Size of the lesion and number of the lesion, and extend the lesion, and also note the dimension of the or the number of the lesion. These all are the important factor when you are managing the patient as a wire positive. So when you label as a wire negative, you must see this type of the picture. Then when you, this first picture, you say simply it is the wire negative, and there is this squamous epithelium all over the cervix, and it's clear cut. You see the pink, smooth squamous epithelium. On the second picture, you will see that in this, after the application of the acetic acid, you see the scomocolumnar junction, because the columnar epithelium of endocervical canal is exposed on the ectocervix, and they give the appearance of the red color, and this is known as the ectopure. So you see the clear-cut demarcation of the scomocolumnar junction. It is the normal picture, and you should label as the normal and wire negative. And in this case, you will say, if you will see some satellite lesion on the anterior lip, this is the satellite lesion. There is a geographically satellite lesion, but it is not attached to the scomocolumnar junction. So this is not significant, and you label as a wire negative. In other side, you will see that is the patchy acetowhite lesion on the anterior lip to the scomometaplasia. So what what is this? This is the scomometaplasia lesion. You will see where the columnar epithelium is changed into the squamous epithelium. That's why it is showing the patchy white area. So the squamous metaplasia is normal physiological process which is going on in adolescent age group or in the childbearing age group. So this lesion, you will always keep in mind, this is the faint acetowhite lesion, but it is not a positive. When this is the another important picture which you come in day-to-day practice, that the polyp is, you see there's a faint acetowhite epithelium, and this is the polyp you protruding from the cervical. Of that, one important thing, when you are doing the wire test and you are removing the polyp, always send for the histopathological examination to see any changes in the polyp. Acetowhite area also see in the anterior lip of this cervix, and this is the Nabothian cyst, taking the acetowhite appearance as a white acne or pimple, because sometimes the Nabothian cyst is nothing but it's showing the endocervical gland is blocked and there is a collection of the fluid. So it is a faint white area. So these all pictures are showing, but there is a faint acetowhite lesion, and that is not significant. When we see as a positive wire lesion, you must see the scoring when there is a distinct, well-defined, dense, opaque, or dull white or austere white acetowhite lesion, and the lesion will appear very soon. So opaque acetowhite area seen in the first picture, that it is arising from the scomocolumnar junction, and it is a clear-cut acetowhite lesions. And also you can easily identify the well-defined opaque acetowhite lesion in the anterior lip, which is arising from the scomocolumnar junction. Another picture, when you are this type of picture, you can easily identify. There is no doubt about the identification of this type of the. So the wire test is very easy test, and result will be immediately. You will see the patient if there is a high grade lesion or any change. So note the thick, well-defined opaque acetowhite area arising from the scomocolumnar junction in the anterior and the posterior lip. And the posterior lip lesion, see, this is a clear cut. You can see the posterior lip lesion is extending into the endocervical canal. So there is a significance that this lesion is going inside the endocervical canal. In this area, you can see there is a dense acetowhite lesion which is raised and rolled up margins around the external os and involving all the four quadrants of the lesion. So another important thing which I have mentioned, that you will note how much quadrant of the cervix is occupied by the white lesion, because the management according to that we have to do with the wire positive patients. In this case, you can easily identify that very dense acetocyte area all over the cervix, involving all the 4 quadrants and extending into the cervical. It may be the high-grade lesion or invasive lesions, and the lesion will be immediately, as soon as you apply the acetic acid, that it will show this type of lesion. This is a clear-cut picture. When you apply the acetic acid, there is bleeding and there is the type of the growth you can see on the cervix. So the advantage of the VIA, as we all know, that it is a test is very quick. When within a minute you will see the result, but you have to wait for a minute and see how easily you can identify lesion. And it is a non-invasive procedure. You explain the patient in detail about the test is it is inexpensive, require minimum equipments, require minimum trainings, and can be performed by the paramedical staff, and the result will come immediately. And most important, very high sensitivity. However, the disadvantage that VIA has 2 disadvantages. It low specificity and miss the endocervical lesion and may lead to the over-treatment. So to overcome this problem, 8 to secondary trials test for the VIA positive patients. So if we are doing the VIA as a primary screening test, at the secondary trials test to reduce the false positivity rate of the VIA, and this will improve the specificity of the VIA test. So VIA test with magnification, that will definitely increase the sensitivity and the specificity of the VIA test. And if we'll do with the VIA positive patient with the HPV test, and it will increase the sensitivity, because VIA test is has the low specificity. With the HPV, it will increase, and by colposcopy we can identify the lesion where it is present. So these are the secondary trials test. The another important things which I want to discuss, the smartphone and with the acetic acetate. It is the innovative tool to improve the cervical cancer screening in low resource setting. The traditional VIA with the naked eye is associated with the large variabilities in the detection of the precancerous and with the lack of quality control. So the digital VIA, DVIA, used as a high definition camera, allow the magnification and zooming on the transformation zone in a suspicious cervical region, as well as the simultaneously compare the native and post VIA image. It means before the test you can take the picture, and after the post VIA image you will take. So you can compare both the image, and in low resource setting using the smartphone device for the DVIA based cervical cancer screening program is definitely very useful for the low resource settings. The available study results show that the quality of DVIA image is satisfactory and enable to diagnose the CIN1 and CIN2. A smartphone is promising tool for the cervical cancer screening, monitoring, and for on and off site supervision and training. So if anybody, any nursing staff, any paramedical staff or healthcare workers take the picture, they can send to the higher center and take the advice that there is the picture, and they can take the results. The use of artificial intelligence algorithm could soon allow the automated and accurate cervical lesion detection. So these are the tools are developing, and that will be useful for the low resource settings. And if VIA is used as a primary screening test, in about 15% of cases it requires the secondary trials. But if we don't have the secondary trials as a HPV DNA test or colposcopy, we can take the immediately biopsy, because secondary trials is procedure is difficult or not available. Biopsy of the VIA positive area along with the endocervical cuticles will be helpful. Especially this type of lesion, when the 4 quadrants are occupied with the VIA positive, then you will take the biopsy immediately and you will come out with the results. Single visit and screen the treat. That is the important things. In developing country, 80% women do not return for the treatment after the screening. The disease, the decrease the efficacy and of the screening program of cervical cancer. And the alternative VIA positive patients should be treated with the cryotherapy or thermal coagulation at the same visit. However, it will be result in over treatment sometime and underdiagnosis of endocervical or microinvasive lesion. Patient should be followed up by the HPV test after the treatment. So this is the clear-cut guidelines which is given by our own FOGSI and GCPI, in which the VIA test should be done between the 30 to 65 years, preferably between the 50 years. If patient is VIA negative, return after the 5 years. So it is very simple test, and you allow the patient to come after the 5 years. If it is a VIA positive, whether you will like to treat the patient, screen and treat at the same then you go for the lesion. If the lesion is appropriate, go for the ablations or the thermal coagulations. So for the eligible of the screen and treat patient, lesions should be entirely visible on the cervix. Entire lesions should be located on the ectocervix without any vaginal or endocervical extension. Lesion can be adequately covered by the large probe of the cryo. So the whole of the lesion will become, or you can use the thermocoagulation by the multiple application. There is no suspicious or invasive lesion. It means you can identify that there should be no four-quadrant, or it is the suspicious for the lesion. Screen and treat by cryotherapy is contraindicated in case where the postcoital, postmenopausal bleeding, and there is an obvious growth. So this is a simple way we screen and treat the patient. But if you want to do the secondary trials, we go for the colposcopy. If the colposcopy picture is showing the normal, allow the patient to come after 5 years. And if you will take the biopsy with showing the different lesions, CIN1, 2, then go for the treatment according to that. That will be discussed later on the by the speaker. So the criteria for the various single visit approach study. Yesterday we heard about Mr. Paul. He said that is the best way to single visit approach study. Whether we have at the resource center where we have the colposcope, we go see and treat. But in the public health program, we screen and treat patients. The single visit approach study is the most important study for the prevention of the cervical cancer. Paul has many stress about that we screen the patient and treat at the same time and detect the test by the via abnormal lesion. Criteria for the ablation fulfill, which I have just discussed about it, how we will go for the ablation methods and what are the criteria for cryo or thermal ablations, and lower probability of this over treatment in the high prevalence area. And I mentioned about the biopsy. We will take the biopsy before the treating, we will analyze the case. That is the way that everybody is appreciating. In the large population, we go for the single visit approach that will definitely control the cervical cancer and feasible in our country. The cost of the via is hardly anything, and the pap smear is varies from the 150 to 250, and HPV DNA is definitely cost-effective methods for the testing. So to conclude my talk, via is a method for choice between the 30 to 50 years. If negative, follow up after 3 to 5 years. Positive, secondary trial test if possible, and then refer if you have any doubt about the test. So VIA is the ideal and appropriate approach for the control of cervical cancer in India. VIA is highly sensitive and inexpensive test in women between 30 to 40 years of the age. VIA must be done single lifetime, reduce the incidence of cervical cancer by 26%, showed by many studies in different parts of the country and other parts. Create the awareness in general population. That is the most important, but the public awareness is very important about this screening, because in our country, the screening program is very poor. It hardly 15-20% and varies from state to state and the city to city. 1 minute 2-hour gynae examination to all the students whosoever is attending this program. They spend 1 minute in gynae OPD for the screening of the cervical cancer by any method, at least with the VIA test, and that is your routine gynae examination. With the clinical examination, you do the VIA test. It will definitely fruitful for the management of the cervical cancer. Until the HPV tests are available, the moment of can use the VIA should not be lost. In limited resource country like the Bangladesh, other part of the country, India, where the disease burden is very high, VIA-based screening programs are introduced with a varying degree of the programmatic organization and performance. The affordability and simplicity of VIA test help in training a large number of the healthcare personnel for screening and led to the development of the multi-level coordination between the healthcare system. Because in our country also we have the multi-layer healthcare system at the CSC, PSC, district hospital, then trustee. So we cannot have the one test at all the level. So whatever the test is available at any place, we have to, and Government of India also recommended the VIA test should be at the CSC center. Thank you so much for patience hearing.
Thank you very much, Veena madam. Excellent. And now we go for another very important test, which is VILI. I will like to share my screen. Now for inviting Dr. Helen for this. Dr. Helen, are you available? Are you there? Dr.
Yes,
Helen, are
ma'am.
you there?
Yes, ma'am. I'm ready. I'm about to share
You're
my
ready with your
screen.
presentation? All right. So
Yes,
Dr.
ma'am.
Helen is the Associate Professor of OBGYN Jawaharlal Nehru Institute of Medical Sciences, Imphal, and in charge of Gynae Oncology Department of OBGYN. She is also a member of various organizations. So over to you, Dr. Helen, for your talk on VILI. Kindly go ahead and unmute yourself.
Okay, ma'am. Thank you so much. And I'd like to thank Dr. Veena for making my work very easy. She has explained various important aspects about VIA in such a way that half of my work for explanation of VILI has been done. So since late afternoon, we have been hearing all our esteemed seniors speaking about the wonders of what HPV DNA screening and pap smear screening has brought about in controlling cervical cancer. But what does direct visualization of inspection of cervix testing like VIA, really, how do they help in cervical cancer screening test? Madam Veena has explained so convincingly regarding the utility of VIA. I'd like to contribute my part in explaining why VILI is as important, especially in low resource settings. Before I speak about VILI, I think these personalities deserves mention because they helps us understand how the visual inspection with Lugol's iodine concept started. So it was a French physician by the name of Jean Lugol who originally indicated iodine solution for disinfection and detection of starch. Another personality, Mr. Paul Ulrich, he made an important observation about the selective iodine staining capacity of the squamous epithelium of the cervix. In 1928, Lambs made an important observation. He noticed that the glycogen content of squamous epithelium cells, they seem to decrease as anaplasia increases. Now, this was the basis for the development of, I think, Lugol iodine test. And this concept, this observation was finally proven by Walter Schiller in the same year. And that is why that is how the Schiller's iodine test came into being. And he had recommended this as a screening method for cervical cancer. However, in doing so, he also noted that certain deviation from the norm, like non-neoplastic cell changes, can also bring about the same observation as in anaplastic cells, that there might be decreased staining with iodine. Having said this, I'll come to Lugol's iodine. What is Lugol's iodine? Well, it is actually an aqueous solution containing 5% iodine and 10% potassium iodide. Aside from its use as reagent and antiseptic, it has been used in other malignancies also. Now, the idea behind usage of Lugol's iodine for testing and mention of glycogen was that it was found that iodine binds to the alpha-1,4-glucans found in polysaccharides like glycogen. So this is the principle behind the visual inspection with Lugol's iodine screening test for cervical cancer. Now, like Madam Veena said, not much is required when we do VILI testing. So we at most need Lugol's iodine, gloves, the most basic of the basic infrastructure, which we usually use in all health sector. These can be used. These are already available there. So there is not much, excepting I think maybe in procuring Lugol's iodine. That would be the main problem. Lugol's iodine, what we need to know is that it can be prepared easily also. So in order to prepare Lugol's iodine, we need potassium iodide 10 gram, iodine crystals 5 gram, and distilled water 100 ml. So it's all about when to combine how. So we start with dissolving potassium iodide, the 10 gram potassium iodide in 100 ml of distilled water and stir it continuously. Simultaneously, we start adding iodine crystals slowly. Once all the crystals are absorbed, the preparation is then stored in an amber colored bottle and labeled, because the preparation can be used as a shelf life of about 1 month. So in order to understand how the Willi works as an effective screening methodology, all our previous speakers have talked about the anatomy of the cervical of the cervix. I'd like to just go through it once more. So we know that two types of epithelium cover the cervix. So there is a part of the cervix which we know as ectocervix. This is lined by a stratified non-keratinizing glycogen containing squamous epithelium, and they tend to be multi-layered. So these epithelium are separated from the stromal tissue by basement membrane, and just adjacent to the basement membrane, we have basal cells from which the parabasal intermediate and superficial, over which the parabasal intermediate and superficial cells arise. What I mean to say is the basal cells will keep maturing towards the superficial layer, and as this goes on, you'll find that the intermediate cells and superficial cells, the cytoplasm component increases with increase in glycogen component and decrease of the nuclear component, as we can see from the picture here. So we have this superficial layer, intermediate cell layer, and parabasal cell layer. You see the cytoplasm content is much more compared to that in the basal cell layer and the parabasal cell layer. So the endocervix is lined with columnar epithelium, a single layer. So they don't have cytoplasm in the, glycogen in the cytoplasm, and there's this nuclear protein. That is why there is no uptake, because when we put on Lugol's iodine over this tissue, so because of the easy staining of the iodine with the glycogen, so when we apply Lugol's iodine over the ectocervix, there will be uptake of the stain. But in endocervix, there won't be any uptake because they don't have glycogen. However, I'd like to make a note of the fact that in menopausal female, the epithelium, they do not mature beyond parabasal layer. So collection of superficial and intermediate cell layers are not there, unlike in reproductive age group. So interpretation of iodine test in such group of patients might be difficult. So the visual inspection with Lugol's iodine, after having explained the procedure to the patient, we put the patient in lithotomy position, do a general inspection, then visualize the cervix after insertion of the speculum, visualize the cervix with naked eye. Having done this, we apply Lugol's iodine over the cervix and adjacent tissue, and the color changes are noted. So obviously this, how the test is done is very easy. Interpretation is as easy as the test itself, in that we interpreted it as negative, Willi negative, Willi positive, or Willi suspicious for cancer. What is Willi negative? What is Willi positive? What is Willi suspicious for cancer? Well, so when we say Willi negative, that means we are thinking of that there is, in case of Willi negative, there is no iodine negative area. That means there is no negative staining. There is no iodine negative staining area. I'll make it clearer in my next slide. In Willi positive, so there is iodine negative area. That means there are areas which does not show uptake of iodine staining. Now, when do we say Willi suspicious for cancer? So if we find an irregularity in the cervix, irregular growth, or a raised portion noted in cervix, and if they test negative for iodine staining, then that is Willi suspicious for cancer. Now, that staining pattern can be understood better when we go through this. So for a mature glycogenated epithelium, So that means these cells, they have glycogen. Therefore, they stain easily with Lugol's iodine. So how does the stain appear? The tissue will appear brown. But in partially glycogenated tissues like immature metaplastic squamous epithelium, incomplete atrophic squamous epithelium, and even L-cell, the staining patterns tend to differ range from yellow to brown. In non-glycogenated, supreme example being that of cancer, there is no stained uptake, and there might be a yellow staining. There might be a yellow stain also. In case of high-grade squamous intraepithelial lesion, the staining pattern may vary from yellow to ochre. But this unstained area, as I said earlier, in cancer, though it appears in cancer, even in columnar epithelium or immature metaplastic squamous epithelium, in atrophic squamous epithelium, usually these tissues also don't stain with iodine. So this is something that we must remember while we are doing screening. So interpretation of the result is can be understood better when we read this slide. So iodine positivity means there's different shades of brown. So this is normal finding, really negative, right? But for iodine negative inside transformation zone, usually indicative of high-grade lesion, they tend to stain yellow in color. Now this implicates an abnormal finding, and so warrants follow-up. For iodine negative outside transformation zone, they usually are found in squamous epithelium, which are non-glycogenated, like those metaplastic epithelium, and low-grade squamous intraepithelium and congenital transformation zone. These are usually non-specific change, even though they are categorized under abnormal finding. So this staining pattern and how to interpret the positivity is what we should know when we are doing Willi. This is an example of negative iodine staining. So because the iodine negative staining, it is in the transformation zone. This is considered, can be considered a high grade lesion, and this in fact was confirmed by histopathology later on to be a high grade squamous interepithelial lesion. Another example of iodine negative area is this two. We see two areas, one near the one in the transformation zone and one away from the transformation zone. Now, later directed biopsy from this area revealed that the one in the transformation zone revealed the histopathology came out as high-grade squamous intraepithelial lesion. Now, this area, which is away from the transformation zone, showed metaplastic tissue, the normal squamous tissue. Now, this is more of a complex iodine negative staining. So the different patterns of staining can be seen out here. So this particular area, which is which is in the transformation zone, was found to have high-grade squamous intraepithelial lesion, and these patchy areas that we see here was found to have a histopathology reading low-grade squamous intraepithelial lesion and part metaplastic lesion. So this is how we diagnose whether a patient is having Willi negative or positive. So in case of Willi negative cases, obviously we won't be seeing any of these negative iodine staining area. We would be seeing a brown stain, uniform brown stain overall. Obviously, like our previous speakers have said, detecting the cases is important, but it is also imperative that we follow up these particular cases. We can go for the single visit approach if we get a really positive cases, and then we find that they fulfill the criteria for ablative therapy, then we can go for the single visit approach and treat them. Another option for such kind of positive cases would be to refer them to where colposcopy and guided biopsy can be done. In case of Willi suspicious cases, colposcopy and biopsy is a must. It should be done. Now, we know that iodine, we do a regular iodine staining test in all our colposcopy when we do colposcopy, because we keep certain scores, and this helps us in assessment of pre-cervical lesion, right? And you can see here in the iodine staining part, they have given for brown staining a score of 0, for faintly or patchy yellow a score of 1, and for distinct yellow a score of 2. Now, why am I saying this? Because we need to, with this will help us understand the concept of Willi better. That's why I'm sharing. So these are colposcopy pictures. This is of a normal colposcopy finding. Here you see the transformation zone has stained a beautiful brown, and there is this columnar epithelium does not take up the iodine staining, so it is appearing as a bit yellowish. This is also another example of Willi negative case. So in the transformation zone, you do see some changes, but then the thing is, it is more of a patchy in nature, and you can see one Nabothian cyst out here. So this change that we see out here is not surprising, and the fact that this doesn't appear to be high-grade lesion was confirmed by histopathology later on, and graded as a metaplastic squamous epithelium. So this is an example of Willi positive case. Where, why I say this, now you see this is the appearance of the cervix after normal saline, after cleaning it with normal saline, and now in the picture on the right side, you see there are 2 areas which is touching the squamocolumnar junction. You see this distinctive white area which has not taken up any of the stain. So this implicates high-grade lesion, and there was a sweet score also had come out to be around 8, and biopsy from this area had showed high-grade squamous intraepithelial lesion. Now, having said that, obviously, whenever we think of any screening test, we have to know what is the performance status of that particular test. Until the advent of pap smear, we know that this Schiller's iodine staining test was the screening test that was used for screening of cervical cancer. Because of the after the advent of the pap smear, it was totally replaced. So pap smear started coming up, then HPV came up. So it had taken a backseat. But then there was this study done by the International Agency for Research on Cancer. So this was a multi-center study, and it was done in India and Africa. It involved quite a lot of a big study population, and the purpose of this study was that they were trying to estimate and compare the sensitivity of both these low technology screening tests, which are VIA and Willi, to detect high-grade cervical intraepithelial neoplasia. The study also tested the accuracy of these screening tests. And the results, as we can see on the left side, both had good sensitivity. However, the sensitivity of Willi here, I'm sorry, I didn't label it properly. So this column here shows the results of VIA, and the result on the right side is that of Willi. So the sensitivity, as we can see, is much, much higher. And it was definitely significant that Willi did turn out to be more sensitive than VIA for screening of cervical cancer. In terms of specificity, positive predictive value, negative predictive value, the figure did not differ much. But I think this figure ultimately showed that Willi appears to be more accurate visual test for use in screening. and treatment programs in low resource settings. So what is the limitation? Limitation, we already know the specificity is low, objectivity definitely is lower, and interpretation in postmenopausal females is difficult. And procuring the ingredients for preparation of Lugol's iodine may also be a problem. However, we must not forget the advantages that it is a very simple procedure that requires minimal infrastructure and that it has high sensitivity. And another feather in its cap is that we have immediate results, which may help very largely in applying the single visit approach during mass screening in health camps. So screening, visual inspection with acetic acid screening, visual inspection with Lugol's iodine after application of Lugol's iodine, even though it was introduced in 1930 and was a recommended screening procedure, and though it had to take a back seat because of the much superior test much superior test introduced in the form of pap smear by George Papaniloko. The effective, the talked about effective screening technologies like HPV DNA and pap smear, they are like very important and good source, good form of screening for good resource settings. But in low resource setting, especially low middle income countries like ours, and I can speak for my area where I'm following VIA, so it really helps. So visual inspection with acetic acid, even though it had taken a backseat.
We are already run late. I mean, that
thank
time
you,
is
ma'am.
long.
I think I'll conclude my slides here only. It's my last slide. So I think Willie is starting to emerge as an important player in the field for low resource setting screening for cervical cancer. Thank you so much for your patient hearing.
Thank you very much, Dr. Helen. It was
Yes,
really
ma'am.
lucid. And now we go to the next. I'd like to share my screen for inviting our next speaker. In this session, it is so here we have, after hearing VI, VILI, we have IHC tumor marker, and for that, we have an eminent speaker, Dr. Sarita Shamsundar, who is a consultant and professor of Vardhaman Mahavir Medical College, Safdarjung Hospital, New Delhi. And she is accredited colposcopist of British Colposcopy Society, and she's been the immediate past president of ISS, Indian Society of Colposcopy and Cervical Pathology, which is termed as ISCCP 2018 to 2021. Over to you, Dr. Sarita, to share your slide and inputs on IHC tumor marker, which is the talk of the town today, and we really want to know more about it. Can you unmute yourself? Can you unmute yourself, Dr. Sarita? Can you unmute? Is there any problem? Yeah.
I've actually logged in from my phone also. I just want to log in from my laptop. I'm not being allowed to unmute myself from the laptop.
Jignesh, can you take this up? There is an echo because she's joined from 2 devices.
Ma'am, I have made you the co-host for the computer also. You can share the screen now.
Yeah.
Ma'am, can you please put off the speaker of one of the devices?
Yeah, I have to go. Okay. Okay, better now?
Still an echo is there, Sarita?
Okay.
You can log out of one and then take the computer one, right? So in the meantime, there have been a lot of questions, and yes, Dr. Helen, very good to reply. I was about to say that. Okay. So here I think Dr. Sarita Shamsundar has been sharing her screen.
Can you see my slides?
Yeah, we can. Kindly.
I'll just put it on.
Sorry for the delay in logging in. Okay, I was in the OT. Okay, so talking of, my topic is on biomarkers for pre-invasive lesions and invasive cervical cancer. And thank you, Dr. Priya and ICOG for this invitation. So why do we need biomarkers? So although the PAP test, it brought about a 70% reduction in cervical cancer in developed countries, but we all know there is a high inter-observer variability, and you can have a lot of false negatives and false positives, but many false negatives. And now we have the HPV test. So this is very sensitive, but it needs to be triaged by second test because of the high sensitivity. So we all know this human papilloma virus. It's a non-enveloped virus belonging to the family of Papoviridae, and it has the L1 and L2 protein, which actually code for the SID, and the HPV DNA is the long control. The L1 region codes for the protein, whereas the E6 and E7 are the potent oncogenes. So if you look at HPV carcinogenesis, now the HPV actually integrates into initially the HPV infection. The HPV stays outside the nucleus, and then later on it gets integrated into the nucleus, and then it gets integrated into the DNA of the cell. So till the time that it is not integrated into the cell, there is a possibility of HPV clearance. The moment it gets integrated into the DNA, that is the time it starts developing high-grade CIN and then some cervical cancer. So this is what the Haralzer-Hausen hypothesized. The HPV entering into the epithelium and going right down to the basal cell, where it stays outside the nucleus as a small plasmid. So this little red ring is the HPV virus, and later on it gets into the nucleus, and this red ring has gone into the nucleus of the cell, and till then it can, till this stage the viral infection can heal. So 90% of them heal within 2 years, whereas once it gets integrated, if the virus persists, it gets integrated into the nucleus of the cell, and that's where you find that it is going into it's just put my point. So that's where it can integrate and then develop high-grade CIN and then cervical cancer. So this is what we need to identify. We need to identify, which are the infections, which are those HPV positive women who can clear, and which are those which HPV positive women. So in what stage is it? So HPV infection, is it still just an infection, or is it going into a high-grade lesion? So this is the same thing, but you can see that as initially, the infection, the initial stage of HPV infection, it is a productive infection. So it starts producing the cells also have a lot of HPV virus in them. So you have these green cells are actually these cells having the HPV virus. And in this stage, the E6 and E7, the number is less, and you can see only the surface. So the L1 gene actually is more. So you can see this green part is actually the L1. Now, once the infection actually the virus integrates into the cell, that's when the E6 and E7. So this red arrow that you see, the E6 and E7, it's increasing, and the number of these green cells is decreasing. So that's when it's going into high-grade squamous intraepithelial lesion, that is CIN3, and then it develops into cervical cancer. So this is tells you, where actually is the E6 and E7 gene acting. So normally, you have the cells have, our cells don't multiply too much. There is every cell, it goes into a certain, it does multiply, but then there is a stage, it stops at a particular point. So what is this process that is stopping and controlling the cell multiplication? This in an uncontrolled, our cells don't multiply in an uncontrolled, in a normal patient. So what happens is, because the cells are destroyed by a process called apoptosis, and for this is important is P53. So this P53 is important for the regulation of this, for death of cells, so that normal cells, other cells can develop. Whereas, and you also have this retinoblastoma protein. So this, and there is phosphorylation of this. So normally because of this phosphorylation, and this is actually activated by this cycle-independent kinase, and it is blocked by P16. And there is another protein called E2F. And so this also activates P16. Now this E6 and E7 are going to act at the level of P53. So if it's going to block the suppressor gene, so the cell is going to proliferate. And also this, it's going to also act at the level of the RB, that is, this is going to block the phosphorylation of this retinoblastoma protein. So again, there is no activation. Now this is going to block the cycle-independent kinase, and that's why you have a very high P16 level. P16 actually keeps accumulating because of this block. So that's why you have a very high P16 levels. So this is what the same thing you see in this diagram also. So apart from P16, you also have increase in the Ki67, which also indicates, which is we'll come to that. It also indicates mitosis in P16. So biomarkers can be, so the different types of biomarkers, the genomic, transcriptomic, metabolic, or it can be proteomic, immunohistochemical, and others. And they are used either for prognosis or for prediction and or for both. So as I just told you, this E6 actually, it also causes activation of telomerase related genes, and it causes immortalization of cells. So the cells don't die. Okay, and also it's going to act at the P53, which we just saw. So it's going to stop the P53, which is a tumor suppressor protein, and that's going to stop apoptosis. So the cells will not die and they will get immortalized. And the E7 is going to block the phosphorylation of this retinoblastoma gene, and that's going to increase the E2F. And there is aberrant proliferation. The cells keep proliferating, and that's why you get this increased Ki67. And also there is inactivation of tumor suppressor genes by methylation. So this virus also causes methylation. So all this, this causes an increase in the P16, and what is going to happen is the cells are immortalized, and that's when the HPV gene gets getting integrated into the host genome, and that causes transformation. So how are these biomarkers are going to help us in cervical screening? So you have this Ki67, which is actually a nuclear staining pattern, and this increase in the Ki67 staining reflects increased epithelial cell proliferation, which you find in HPV infected tissues, and it's a measure of cell proliferative capacity, and recognizes tissues which are involved by HPV, and the extent of this Ki67, it generally parallels increasing grades of dysplasia, and it's usually used in histology applications. Whereas P16, it is both nuclear and cytoplasmic, and the levels are increased in response to irregular cell cycle inactivation, as we just saw because of the HPV effect. And detection can actually help as a surrogate marker for persistent infection with high risk HPV. And it's also used for triage of equivocal cytology findings. When there's a difficulty in making a diagnosis, whether it's high grade or low grade, that's when it helps. And it also helps in interpretation of histology. Now there is another of these biomarkers, is BD-PRO-XC, which is also a nuclear biomarker, and you find increased levels of this when there is aberrant transcription of S-phase proteins, and that causes because of interaction of HPV E6 and E7 with cell cycle proteins, and this is also helpful for differentiation. So we'll come to this part also, and it's also useful for distinguishing histology from true dysplasia from mimics, such as reparative changes. And then you have cytoactive HPV-L1, which is actually from the HPV-L1 capsid protein, and you find it in mild to moderate dysplasia, but it's lost in high grade intraepithelial. So it's the opposite. So normally the others are increased when there is high grade, but here it is decreased when there is high grade lesion. So that's a pictorial representation. So you can see that the Ki67, it is in LCIL, it's less, but here you can see the staining is increased in high-grade lesions. And the same with P16, you can see that it is less, this brown staining. It's less in the LCIL, but it is there. And you can see it's much more in the high-grade lesions. And in the BD Pro XC, again, and this is actually in cervical cytology specimens, and you can see that here in the high-grade lesions, it is much more. And the same whereas in the cytoactive HPV L1, you can see that the staining is less in the high-grade lesions. So how do these biomarkers improve screening? So what they have, because cytology is also subjective, so somebody has to interpret the smear whether it is and say it is normal or ascus or LCIL. So especially in the differentiation of ascus and LCIL, it becomes difficult. That's when this Ki67 immunocytochemistry has been found to increase the sensitivity for detection of high-grade lesions. And in fact, a meta-analysis of 27 studies using P16 immunostaining in cytological specimens, and they found that 12% of normal smears were positive, whereas 45% of ascus and LCIL and 89% of HSIL smears were positive for P16. So so that improves the sensitivity and the specificity of the test. Otherwise, the pap smear is only 50% sensitive, but if you add these biomarkers, the sensitivity increases. And similarly for HPV positives, so which are the HPV positive women who actually have CIN lesions? So this was a NTCC, which is a Technologies for Cervical Screening, a randomized controlled trial in Italy, where the P16 triage of HPV positive women was done, and they found very good sensitivity and specificity for diagnosis of CIN2 and 3. Some faint P16 positivity you can find in atrophy and metaplasia. A dual stain is P16 and Ki67. It's a combination. So it's a biomarker cocktail. It's again, if you apply it for borderline cytology and even in cytology negative, but HPV positive cases, they found that it helps in the detection of high-grade CIN lesions. And this was also in the European equivocal, the EEMA and MAPS study, which is a big study. Again, the BD Pro X, again, this was also helped in the detection of high-grade CIN lesions in ascus positive BD. If the same pap smears where they applied the BD Pro XC and found that those who were positive, they had a high likelihood of having high-grade CIN lesions. And also for reflex application of high-risk HPV, the HPV positive, and then you apply this and to see whether those who have the high risk, who have CIN2 lesions. So this was found to increase the specificity of detecting those who are having CIN2. And that helps actually in decreasing the colposcopy procedures. Otherwise, you will be calling all the HPV positive women for colposcopy. And it also helps for the histological classification of cervical biopsies. So you take a cervical biopsy, sometimes, pathologists may not be able to differentiate whether it is a reparative change, if it's immature squamous metaplasia and atrophy. They mimic high-grade lesions and can cause problems in histological interpretation. So this is when biomarkers can help differentiating true dysplasia from this dysplasia mimics. So if these biomarkers are positive, that means it is high-grade CIN lesion. And here again, so you see this biomarkers have been applied, and in low-grade dysplasia, you can see the staining is much less. This is Ki67, this is P16, and this is BD Pro XC, and this is cytoactive this biomarker, and you can see that the high-grade lesions have very high, the staining is much increased, and you can see that this P16, almost the entire epithelium is brown. Whereas the cytoactive HPV-L1, which I was saying, the higher the grade of the lesion, the lesser will be the staining. So that is exactly opposite of the other stains. And you can also see that it helped in differentiating cyan, low-grade cyan from the high-grade cyan. So you can see, so there were so many studies which evaluated these different stains for the detection of low-grade and high-grade cyan, and the detection of the cyan was much more in cyan 1 and cyan 2. So the sensitivity increased markedly. And which are the cyans which can progress? So this is often a confusion whether to treat or not, and especially the cyan ones, either we keep them under follow-up, but then they can be lost to follow-up. So can we treat these cyan ones and minimize this loss to follow-up? So which are the cyans to treat? So this is how this is where the biomarkers can help. So if you apply this P16 and even in this pro-EXEC biomarker, and they are very sensitive in predicting those cyans which can progress. And even HPV-L1, which is a capsidic protein, as I said, it's expressed in the early productive phase of the HPV infection, but it progressively gets lost during cervical carcinogenesis. So if HPV-L1 is negative, that means it is progressing and it is less likely to regress. So P16 positive, pro-XC positive, and HPV-L1 negative, all these indicate that that lesion is going to progress. And then it also helps very often for P16 because it is specific for the cervix. It helps in differentiating carcinoma cervix from carcinoma endometrium. Very often if it's an endocervical growth, it's sometimes difficult and it's growing into the uterus. It's difficult to know whether it is primarily endometrium or it's primarily endocervical. So that's where these biomarkers can help. So P16 helps in differentiating the cervix from the endometrium. So in summary, the biomarkers can be used to identify the high risk among the screen positive for accurate diagnosis of CIN2 in the histology specimens, and CIN1, which are the CIN1s having a higher risk of progression, and differentiation of cancer cervix from the other cancers. So it's mainly commonly used are the P16 and Ki67, and either the dual stain, either in the cytology, or they're used in the histology. So these are the two stains which are commonly used. Thank you so much for your patient hearing.
Thank you very much, Dr. Sarita, well on time. And now can I request Dr. Hiralal sir to have the remarks on all the three talks which was there now of VI, VILI, and IHC tumor marker. Sir, are you there? Dr. Hiralal sir?
No, ma'am, he is not there.
No, he is trying to log in from that number which I have put it in the chat box. Please allow him to log in from that mobile number.
And in the meantime, we are seeing a lot of good comments on the chat box and a lot of questions which has been answered very well.
Yes, ma'am, I'm looking for it.
I have sent you WhatsApp also and in the chat box also.
So in this, in the meantime, when Dr. Hiralal is joining, now VILI, of course, somebody had put in the comment that IFCPC hasn't given the this thing, the standing of VILI as a primary screening tool. Of course, yes, it hasn't. It is a VIA it is used as a primary screening in the screening programs, and VILI definitely increases the sensitivity of VIA. So that's one thing to be understood. And about the cost of biomarkers, another question which has been there on the chat box. Kindly let me know when Dr. Hiralal has joined.
Ma'am, उन्होंने अभी तक join नहीं किया है, मैंने देखा वो number से.
In the meantime, I can just continue with all the questions which has come up.
Let's start with the third session. Yeah.
Shall we start?
Yeah,
Only
yeah,
one
please,
thing
please.
is a very costly one. Metropolis gives it for around 2,000 for that test, no, P16, and KI16 again goes with around 1,850 or 2,000. So that's another answer for it. And I think should we then go ahead, madam,
Yes,
with
yes, please.
the third session?
Yeah,
And
start with the
for
third session.
chairing the third session, we do have Dr. Vidya Thubi, madam. I have introduced Dr. Vidya Thubi, madam, before. And now we have our third session starting. So now the first talk is on AI augmented with Walter Prendivili. Now he has a commitment. He said that there's an emergency commitment at Dubin. So he isn't able to join, but he has definitely given his video to us. So a retired gynecologist from Dublin and then past president of BSSCP and IFCPC. Now, he is the person who introduced LLETZ, that is large loop excision of transformation zone. We are talking so much about LETs. And Dr. Walter Prendivili was a person who introduced LETs, LEAP, and he has now developed even the new thermal ablators. And he's currently working with NSV, developing as AI image interpretation system and a senior visiting scientist at IARC WHO. So we are very lucky to have his recording. So Jignesh, will you play his recording?
Good morning, colleagues. My name is Walter Prendiville. I'm calling you or talking to you from Dublin on a cold January morning. I'm going to share my screen now to bring up the lecture. This talk is very much a collaborative, the result of a collaborative effort between Itisham, Raymond, Pierre-Martin Hirsch in Lancaster, Som Patak, Ankita Shastri and colleagues in NSV at Allentown, Pennsylvania, Partha Basu and Gary Clifford at IARC in France, and myself who straddles all three. I have to declare an interest with NSV because I'm the Director of Clinical Research there, and I also have shares in Liger, with whom I helped develop the thermal ablation device. So you may reasonably ask, why bother with AI? Well, screening is currently not perfect in many parts of the world. It's not perfect anywhere. Ideally, it would be delivered as an accurate point of care, feasible, safe, acceptable, and affordable phenomena. Diagnostic and treatment services also need significant improvement following screening of a population. The entire management pathway needs to be completed in the least number of visits. And there's consensus in WHO that the lack of a better screening test and an efficient management algorithm is a serious impediment to the ambition of eliminating cervical cancer. Colposcopy training is rarely comprehensive. Colposcopy service is rarely quality assured. And patient throughput is often very low, preventing experiential improvement. There's also a variable understanding of what colposcopy should be used for. The IFCPC / IARC WHO colposcopy training course I thoroughly recommend to you. However, colposcopy takes about a year to train an individual, nurse or doctor. And image recognition skills, once gained by a computer, has the capacity to train or inform many thousands of individuals concurrently. Don't forget, AI has taught a car to drive. If you look at the alternatives for screening at the moment and triage, VIA, I have to say, I don't think has worked. Quality assurance is really difficult. It's a hugely subjective exercise, and its test characteristics, when assessed objectively, are actually very poor. The inadequacy of VIA see and treat is very clear. It's an ectocervical examination. It's never going to be able to see the endocervical canal. It's very hard to determine exactly where the SCJ is with VIA, and that's crucial to determine what treatment is appropriate. HPV, cytology, and other laboratory-based current tumor markers, they're expensive, they're laboratory-based, they don't perform rapidly, they need body fluids, and they are therefore unacceptable in the great majority of regions in the world at this time. AI has been very successful in other image-based medical diagnosis. The use of convolutional neural networks in lung, skin cancer, retinopathy, colorectal, breast cancer, and cardiology are all well established in practice. And recently, there was a really good review in Nature last year, just 2 months ago, by Schmatko on histopathology and AI's use there. Thinking about it simply, artificial intelligence is basically something like an abacus. It's algorithmic. A computer program is excellent at following rules for binary or indeed larger classification. When properly trained, a computational analysis program to identify an image as being A, B, or C will do so reliably. It doesn't really matter how complex the task is because it's algorithmic. And so the program simply follows the pathways it's been trained to go down. As with an abacus, if you set up the system appropriately, it will follow the rules, unlike many of us. Now, I'm not a statistician, and I don't want questions about the stats, but the use of convolutional layers in a convolutional neural network mirrors the structure of the human visual cortex, where a series of layers process an incoming image and identify progressively more complex feature. A CNN is a deep learning method designed for processing structured arrays of data, such as images. CNNs contain many convolutional layers stacked one on top of the other, each one capable of recognizing more sophisticated shapes. Excuse me. With 3 or 4 convolutional layers, it's possible to recognize handwritten digits. And with 25 layers, you can distinguish human faces. Artificial intelligence time has come almost because the perfect storm has arisen. Increased data storage capacity and improved cloud access, increased bandwidth and power per watt, the arrival of sensors which facilitate digitization, and improved device architecture have all contrived to produce feasible, inexpensive AI machine learning devices. So for the purposes of this talk, AI has potential immediate application in 2 technologies: spectroscopy and the interpretation of urine signals, or self-sampling to detect HPV, and then to genotype screen-positive women. Thereafter, the triage of genotypically known HPV-positive women using image capture and interpretation to discriminate between HSIL or cancer and LSIL or normal, as well as determining the TZ type and therefore the treatment method, is a reality. Now, I am not a bioengineer and I'm not a microbiologist and not a chemist, so I'm going to give you a fairly superficial overview of what spectroscopy is. If you look at the electromagnetic spectrum, only a small part of this is visible, and then there's a slightly larger part of it that uses infrared. When a material is exposed to infrared radiation, the absorbed radiation excites molecules into a higher vibrational state. The wavelengths that are absorbed by the sample are characteristic of its molecular structure. The technique can therefore identify molecular structure and investigate sample composition very precisely. The spectral bands are indicative of individual molecular components and structures. Now, until recently, the signals that returned from spectroscopy were so complex that it was very difficult to interpret them. The power of modern computational analysis has allowed relatively rapid interpretation of these signals, and AI has exponentially shortened it. Theoretically, any physiological or pathological change leads to changes in the infrared or Raman spectra, and they allow for precise assessment of the different biological samples, tissues, cells, or cell lines, determination of the dissimilarities of these cells at the molecular level, whereby it's possible not only to evaluate the structure of the proteins, lipids, carbohydrates, and nucleic acids present, but also the changes that are taking place in their chemical structure due to a disease process. The things that happen normally when you apply spectroscopy, you will see stretching, asymmetric or symmetric vibration. You'll see bending, scissoring, rocking, wagging, twisting, different types of bending. Now, this figure shows the spectra of 7 different microbes and the chemical structural variations that distinguish them. For example, the illustration on the left shows the spectra of 7 microbes in fluids, which reveals differences specific to different infections. On the right, the 2 different peaks in this image reflect the difference between healthy and diabetic patients. Progress in spectroscopy has facilitated very low-cost spectrometers, $10,000, that are robust, portable, small, easy to operate, and require relatively cheap consumables in the order of less than $1 per test. The results are instant, reproducible, and reliable. Operating the spectroscope in a clinic at the point of care is facile, simple, and difficult to contaminate. The computation analysis in the associated tablet or Meditab is instantly accessible and doesn't require access to the cloud. So far, spectroscopy of biofluids in large cross-sectional diagnostic studies have been shown to have high sensitivity and specificity in dementia, brain cancers, and indeed endometrial cancer. Early proof of concept studies have demonstrated similar potential in urine testing for gynecological cancers. 3 studies evaluating the detection of HR-HPV on cervical samples have observed sensitivity of 94 to 100% and specificities of 97 to 100. No publication has yet evaluated spectroscopic assessment of urine to detect HPV. We have conducted a pilot study of actually now nearly 300 urine samples of known HR-HPV status via banks at IARC. Observer-blinded statistical analysis was performed using these different techniques, and the CNN of the spectroscopic signals from these urine samples in Lancaster. Overall, the prediction of samples performed with the methods above mentioned achieved 100% sensitivity and 84% specificity. Also, a Canadian study led by James Bentley has collected over 200 samples prospectively of women with known cervical disease that have been sent to IARC, have been sent to Lancaster, where Idisham Raymond is evaluating them. So the concept that we have is that a woman who hasn't been screened before would be examined by a urine drop, would be screened by examining a urine drop with a benchtop spectroscope, no pre-processing required. The signals coming back would be interpreted by AI to detect the presence of HR-HPV using a linked Meditab. Now, in screen positive women, HR-HPV positive women, we then need to evaluate them. Learning to become a competent colposcopist is difficult. A preceptorship takes something like 6 to 12 months, whereas a computer image recognition, once trained, can provide the image recognition component instantly thousands of times. So the concept would be that screen-positive women will be examined by the engine image capture system. Cervical images would be interpreted by an AI computation analysis on a tablet to detect the difference between high-grade precancer or cancer from low-grade or normal, and also to determine the TZ type, whereby you can advise the appropriate treatment method. The NCI have used images collected from common smartphones or enhanced camera systems, which are widely available. We personally, we at NSV think the quality of image will be crucial. So NSV and IARC are using a more sophisticated system with a devoted and high image quality camera, dual light sources, emitting white and green light, not filters, and a computation analysis program that is in the AI tablet, so you don't have to go to the cloud. Large volume production will lower the cost of these devices. So this is the Meditab and the camera. The AI training is envisaged or is performed as follows. You feed a large bank of images into the computer. You correlate the image to the peer opinion, perhaps in expert colposcopists, to cytology, to HPV status, but primarily to the known histopathology. So that basically the system will be trained to recognize images that are associated with different histopathological diagnoses. So you have a training set of images, and then you have a validation set, and then you separate all those from the final training model, which you apply to a new set of images. The prospective collection of ideal image selection is now ongoing. The way the Meditab, the NSV engine system works is that you take a low power view 1 minute after acetic acid. You take a view of the squamous lumbar junction if you can see it. You take a high power view of the worst area, and then you take a post-iodine low power viewer again. The system uses a very high quality camera, and the CNN development of algorithmic determination of images is ongoing. We expect to take 1 year to collect these images with sufficient numbers of cancers and high grade, low grade, and normal cases. The ultimate ambition being to provide a device with the capability of providing an instant result, discriminating between high grade or low grade or normal or equivocal or cancer. And if it's a case of high risk of progression, or SIN3 plus perhaps, then the TZ determination will allow the examiner to decide which treatment to perform. AI is here to stay. It will replace many image-based tests, visual and otherwise. Spectroscopy holds great promise, and cervical image recognition and interpretation is already a reality. It needs to be evaluated far more comprehensively than so far, and will be. Including genotype of HR-HPV positive women will enhance the accuracy of the algorithm. The test characteristics of these new techniques needs to be determined in properly constructed clinical trials. A highly efficient, effective, and feasible method of screening, triage, and treatment selection system shows real promise that will cost very little, will be laboratory independent, and will be point of care. Thank you for your attention. I know time is limited, so I've rushed through that a little bit, but I'm grateful for your attention.
So, yes, thank you very much. Dr. Walter has given me a message that he was wanting to join this program, but he has a meeting that's quite an emergency stakeholder meeting, so he isn't able to join us. But yes, his lecture itself is quite self-explanatory. And so now we will be going, I'll be sharing the screen. Now we have another eminent speaker, Dr. Yes. Yeah. So Professor Sabira Khatun. Now, Dr. Sabira Khatun comes from Bangladesh. She's the founder chairperson, Department of Gynecologic Oncology from what is this? Bangabandhu Sheikh Mujib Medical University. That is called as BSMMU. It's quite a famous university. And she has affiliation with Lab 8 Cancer Hospital and Central Hospital, Dhaka, with over 40 years of experience in the gynecological oncology. And she's doing an excellent job. We have heard her once before as well. So I'm sure she's going to really throw a lot of light into setting up of a colposcopy unit. Over to you, Dr. Sabira. And thanks for accepting my invitation to you. And thank you very much to be with us. Dr. Sabira, are you there? Dr. Sabira, she was joining. She was the first person to join.
Yeah. Jignesh?
मैम मैंने उनको कोर्स कर दिया, बट उनके 4 आईडीज है, तो मुझे समझ में नहीं आ रहा है. ये एक और अभी ऐड किया मैंने.
I can see Dr. Sabira. Hi, Dr. Sabira. We can see you.
She has to unmute herself.
Please unmute.
Yes.
Yeah.
Yes.
Welcome, Dr. Sabira, to this ICOG grand program which is going on.
It is a prestigious session, and first of all, I'd like to give thanks to Dr. Priya for including me in this prestigious certificate course of FOGSI and ICOG.
And Dr. Lakshmi as well, because she is the chairperson of ICOG, and she has done an excellent job.
Thank you, Dr. Lakshmi.
Welcome.
Thank you. Now, welcome to FOGSI ICOG online certificate course and Preventive Oncology for Cervical Cancer Elimination. First of all, I want to say some heading of my topic, that is what is colposcope, types of colposcope, indication of colposcopic examination, pre-examination preparation, procedure, post-examination recording, scoring, advices, counseling, follow-up, everything. Now, what is colposcope? A colposcope is a method. Colposcopy is a method of examining the cervix, vagina, vulva in vivo using a microscope known as colposcope and an external white light source. The main objective of colposcopy is to detect the interepithelial neoplasia, early neoplasia, and HPV infection of the lower female genital tract. Now, colposcope, basic of colposcope is that was first discovered by Henselman in 1925. A colposcope is a low-power stereoscopic binocular field microscope with a powerful variable intensity light source that illuminates the area to be examined. Now, there are various types of colposcope. Since Henselman discovered it, the first initial colposcope is a manual optical colposcope, simple binocular manual optical colposcope. In this type of colposcope, the adjustment is done by manually. Light adjustment, that is illumination adjustment, is done by manually. That is stand on the top of a stand and the light source. You can see a light source and the colposcope and the stand. This is a simple colposcope and the very initial colposcope. Now, subsequently, digital colposcope has come, and this is the whole set of digital colposcope. That is, picture is captured. This is device of capturing the picture, and the printer and the colposcopy record is printed out. And this is the whole device, this is the digital colposcope. And another portable colposcope has been using in the remote setting, that is gynocular. And nowadays, the smart colposcope, digital colposcopy powered by artificial intelligence is now on the process of investigation. Now, examination in a colposcopic setting, main is colposcope and coach, chair, or table. There are various types of table. There may be very simple and less costly, and very highly costly and very complicated course. They can be used for colposcopic examination. Now, indications of colposcopy: the glandular or squamous cell abnormality on past but no gross lesion, via VLI positive, HPV DNA positive, postcoital or postmenopausal bleeding, unhealthy cervix, looking cervix, vagina, or suspicious of malignancy, and during treatment of CIN, VIN, and VAIN. Post-treatment follow-up also should be done by colposcope in some of the cases. Now, instruments required for colposcopy. This is the colposcopy table. Use instruments should be required during colposcopy. All are not required during a colposcopy, but it may be required. Some of the list of these instruments are. You can see that the collecting the swab, taking the pap smear, all should be ready in the colposcopy tray. And this is the loop and other setting, and all the, that is normal saline, lupus, iodine, acetic acid, then Monsell solution for checking of the control of bleeding, all should be, that is formalin to collect the biopsy specimen. All these should be present in the trolley. And there are various instruments. All these instruments are not needed during colposcopy, but may be needed. So this should be kept ready. Now the instruments list, that is, you can see that the 16 type of instruments should be kept ready in the colposcopy trolley. And this is the mandatory thing, is the pulse biopsy forceps. Without, if colposcopy is report is positive, then without the pulse biopsy taking, it cannot be sure that it is positive or negative. So all these are, some of the instruments are not always required. As if then vaginal side retractor, it is not always required. If there is lax vagina or there is a prolapse, in this case, vaginal side or retractor is required. And in the cervical speculum is also not always required. When the transmission zone, that is concolumnar junction, is not seen, clearly seen, in that case, speculum is required. And curate also not always required. When there is a discrepancy between the pap smear and the colposcopic findings, then endocervical curate is required. Now, these are the special instruments. We usually use the Cascos speculum for colposcopic examination, and these are special instruments. Nowadays, I think these are not used, but these the vaginal wall side or retractor sometimes is needed, and endocervical speculum, endocervical curate, and the cervical pulse. This is the mandatory instrument during colposcopic examination. And this is, you can see that the vaginal speculum can be covered by a condom and can be used as a vaginal side wall retractor. Now, ideal colposcope setup should have the functional colposcope throughout the ER, so that any patient need not be refused that we have no colposcope, we have no acting colposcope. So throughout the ER, the functional colposcopy should be present in a colposcope setting. Colposcopy course, image capture system, and colposcopy training should be continuous. So that is CME should be continuous. Medical education should be continuous in a colposcope setup. So teaching arm on the colposcope is necessary for training, and teaching monitor on the colposcope is also required during training procedure. And the colposcopy instrumental is mandatory for colposcopy. Information regarding the equipment, that is which type of colposcopy is used in the colposcopy setup. This should be in the colposcopy clinic. And database and linkage is also important for all the facilities, because colposcopy is not a single test. It should be linked up with the screening center. It should be linked up with the other screening center treatment facilities. Now, steps in colposcopy, you know that there is during the procedure, there may be necessary for cervical cytology and the HPV collection of HPV sample may be needed. And first of all, the distance between the cervix and the colposcopic mirror is adjusted. Then cervix cleaned by normal saline, entire circum, so that the entire circumference of the squamous junction and transformation is easily visualized. Next step is apply to our application of the 3 to 5% acetic acid. Then wait for 1 minute. We apply it and look for abnormal transformation zone or acetohyte area. Then application of the Lugol's iodine and look for staining of the squamous epithelium. Now, integration of the colposcopy findings between the acetic acid, Lugol's iodine, and finally read scoring, modified read scoring or sweet scoring is done for colposcopic diagnosis, whether it is in the abnormal or normal, or whether it is in 1, 2, or 3. Then if the colposcopically it is abnormal, then colposcopic diagnosis should be recorded. Then biopsy is taken, and if needed, cervical endocervical curate is needed. And the biopsy is taken from the area which is worst and closest to the squamocolumnar junction. And the biopsy specimen is properly collected, and it is kept in the 10% formalin and sent for histopathological examination. Personnel who are required in the colposcopy clinic: secretarial personnel, administrative personnel, doctor colposcopy, doctor, other doctors, nurse manager, nurse assistants, nurse colposcopist, and medical record staff. Now, in a colposcopy clinic, the spaces and structure of a colposcopy clinic. First of all, there should be a reception place. In the set, first reception desk, and in the reception, after reception, then and in this reception, she will go for waiting room, and in this waiting room, before the procedure, she should have a pre-procedure counseling and diagnostic colposcopy. Then she will go in the colposcopy room, and in the colposcopy room, she should have another counseling session with the colposcopist. And post-diagnostic treatment room, if she is positive, and if she is positive, then she will go for treatment in the another treatment room. And after that, the post-procedural counseling room, that after procedure, she should have a good counseling for the whole thing. And record room, all these should be kept in the record room, record in the computerized record system, and this colposcopy unit and setup should have a secretarial room, that is who will lead all the work in the colposcopy setup. And the doctors in the nurses should have a refreshment room in the colposcopy setup. You can see in a reception room, then waiting and counseling room, then a colposcopy training, colposcopy table, and the cryo treatment. And post-procedural counseling room is very important, because without any counseling, pre-treatment counseling, colposcopy counseling, post-treatment counseling is very important. It's the integral part of the colposcopy setup. And the counseling should be thorough counseling, so that she is not afraid of the procedure. And the record room, these two are the very integral part of the colposcopy setting. And secretarial room and the refreshment room. Now, the setup should have the chart of summary of colposcopic feature guiding professional diagnosis. In every colposcopy setup should have a guide for professional diagnosis. That is for the diagnosis of normal matched squamous metaplasia, or inflammation, or low-grade lesion, or high-grade lesion, or the preclinical invasive disease, or invasive cancer. All these guides should be written in the written paper, should be advised, supplied in the colposcopy setting. According to this guide, the colposcopist will determine the diagnosis of colposcopy. Now, this is the integral part. Colposcopy recording is very important, including the number and age, patient's history, and the findings of colposcopy, that is punctation mosaic. This is a very integral part of colposcopy, and the picture, lesion, size of the lesion, shape of the lesion, all these should be recorded in this area. And this here, the integration of this cytology report, colposcopy report, biopsy report, and ECG report. After integration of these findings, the final diagnosis of colposcopic examination is determined. Now, the consent form, before going for any procedure after treatment for colposcopic, after colposcopic examination, even in case of see and treat clinic, this consent form should be filled up and the signature should be taken. Consent should be taken from the patient. Now, modified risk scoring system, that is in a colposcopy set, there should be a scoring system. All the colposcopy setup does not use the same type of scoring system. Some colposcopy setup use the modified risk colposcopic index. Some may use the Swiss scoring system, and other may use IFCP scoring system. Whatever may be the scoring system the colposcopy setup is, that should be in the written supplied in the colposcopy clinic. Now, Swiss, nowadays, most of the centers are using the Swiss scoring system, and this is very simplified form. And diagnosis of this with this scoring system and interpretation of the Swiss scoring system should be supplied in the colposcopy clinic. Now, modalities. There are two treatment procedures for ablation and two procedures for excisional treatment, and mostly these the four treatment procedures are used in a colposcopy clinic. So, in a colposcopy setup, there should be a cryotherapy machine. Active functional cryotherapy machine should be always available in the colposcopy setup, and cold coagulation system should be available. These are old cold coagulation system, but in a colposcopy setup, these can be used. And this is portable cold coagulator. This is very. This is not so required in the colposcopy setup. It is for the remote setup. Portable cold coagulator is used in the remote setup. It is in a camp and in remote setup. Now, instrument for LEAP should be present or always be available during the colposcopy, because if you want to screen and treat or see and treat procedure, this instrument is required. And sometimes the colposcopic examination and the biopsy report, depending on the biopsy report, the LEAP procedure is required. So this should be available in the colposcopy clinic. Now, good working practices. According to the National Health Services of UK, the good working practices in a colposcopy setup are quality assurance is the most important thing, because in a colposcopy setting, the diagnostic quality, treatment quality, and then counseling quality, and the recording quality, all these quality assurance should be available in the colposcopy setup. Role of a lead colposcopist. In lead colposcopy should always be, she should provide the protocol development. She always protocol according to the recent available evidence. The protocol can be changed, and this should be developed, and this should be continuous procedure. And then the lead colposcopy should always monitor whether this colposcopy protocol is ensured, quality standards are maintained, and collects accurate and valid data. Data collection is important, because without collection of data colposcopy in a colposcopy clinic, we cannot say what is the incidence of 3N1, 2, 3, and what is the result of this treatment. Requisite information should be available, and in the lead colposcopy can have a deputy nomination. He can give a nomination of a deputy for assistance to do all these things. Have a named lead colposcopy nurse, and who will take the day-to-day responsibility for running a colposcopy service and actively involved in the colposcopy clinic. An audit of invasive cervical cancer to monitor the performance of the screening program. And there should be always the percentage, what is the percentage of cervical cancer in a screening program. All colposcopists in the team must be certified, and the colposcopy team should hold operational team meetings at least every 3 monthly. And to reduce the anxiety of clients, always the colposcopy in the setup, information must be provided in written. Written information should be provided before doing any procedure. Before doing any procedure or after any procedure, the written information should be provided about that. That is, if she had any cold coagulation or cryotherapy or LEAP procedure, she should have this information in written. That is, no tampons for 4 weeks after treatment, no intercourse 4 weeks, and avoid swimming for 2 weeks, and driving normal activities and light exercises may be continued ablation and excisional. And she should also know about the complication of the procedures in written. That is that ablation or any procedure is not associated with increased risk of infertility, but she may have some risk of mid-term abortion. All these things should be supplied to the client in written. Now, if the colposcopy clinic follow the protocol of see and treat procedure, then this procedure is very much that is a woman coming for screening. And if we do a invasive procedure that is cold coagulation or cryotherapy or leaf procedure in the same sitting, she is become very afraid of this thing, and sometimes patient complain of that I am not ready to have a operation. So she should have a very good counseling and very correct information should be provided before going for see and treat procedure. And in this clinic, colposcopy clinic, doing the see and treat procedure, all individuals should provide adequate and appropriate information in advance to that treatment. And after treatment, she should have everything, information and good counseling, what it has been done, why she has been done, this procedure has been done, what is the problem with her, and what is the how she will be followed, and what is the subsequent result of this treatment. Everything should be provided before doing this see and treat clinic. History taking, patients should have their history taken and counseled according to her history. Now, clinic facilities. Every colposcopy clinic facility should have the changing facility, toilet facility, a permanently seated room for colposcopy, and refreshment facility and separate waiting and recovery area. So these facilities, for the convenience of the clients, these facilities should have in a colposcopy setup. And this facility should be always working or functional. And sometimes it is seen that the changing room is not active, is not available. Sometimes it is that the toilet is not working. So this should not be always, this should be functional and working in a colposcopy setup. Now, visitors to the clinic, always she will have a procedure, colposcopy, biopsy, and after taking a biopsy, she will have a bleeding. So always she should be have a relative or friend with her, and patient consent should be taken before colposcopy training or undergraduate students and attend the procedure. This is a rule. This is the ethics to have a patient consent before if and trainee or undergraduate student attend the procedure. And adjunctive test. These adjunctive test facilities should be available in the colposcopy clinic. That is histopathology in this in a hospital where the colposcopy setting is set up, where the colposcopy is done. This hospital should have a histopathology facility, test facility, and HPV test. This facility must be present in the colposcopy setup. Colposcopy set up in a hospital where the colposcopy is set up. Now, non-attendance. The number of non-attendance, that is because after doing colposcopy and taking biopsy, she is not coming for histopathology report, and or after treatment, she is not coming for follow-up. And these are non-attendance. Non-attendance rate per clinic should not be less than 10%, and there should be a data of non-attendance in a colposcopy clinic or colposcopy setup. And this non-attendance rate should not be more than 10%. And analysis of non-attendance should be done. Why the client is not coming? What is the problem with her? And there should be a communication over telephone or a message or any other thing. You should have a communication with the client or attendance, and there should be an analysis of to find out the cause of non-attendance. Now, training and certification. The colposcopy must receive adequate certification training. The colposcopy who will do the colposcopy, she should have receive adequate certification training. And maintenance of to maintain the clinical skill and continued medical education. All these colposcopies who will do the colposcopy in the clinic setup, she should have she should develop a clinical skill by training or by continued medical education. Because without clinical skill, the result of colposcopy or the report of colposcopy will not be correct, and there is false positive or false negative rate will be increased. So to avoid this false positive and false negative rate in colposcopy clinic or colposcopy setup, the skill and clinical skill should be maintained, and continued medical education should be always be available. All colposcopy must see 50 referral case per year. So it is a continuous procedure. It is not that the colposcopy come for 10 days and she will do the colposcopy. It is not that the result with the colposcopy will not be correct. So it should be the colposcopist who will do the colposcopy in a colposcopy seat, and she must see the 50 referral cases per year. And all colposcopists must have recertification course, recertification every 3 years. And this is the responsibility of the lead colposcopist to arrange for the certification course every 3 yearly for the colposcopist. So for the correct or adequate or to have a colposcopy, ideal colposcopy examination or ideal colposcopy center, all these points should be obeyed. Now, in conclusion, the quality control is the integral part in setting up a colposcopy clinic. In all respects, quality should be maintained, and all the points should be critically evaluated before setting up of a colposcopy clinic. And continuation of proper service can reduce the false positive and false negative rate of colposcopy procedure. Thank you very much for Thank you very much for giving me the time.
Superbly done, Dr. Sabira. Complete justice given to the topic. Thank you very much. And now we will move on to our last talk, and then we will have the Dr. Vidya Tubi talking about giving her expert opinion on the 3 topics for which she has chaired the session. Now I'll go to the PPT slide, and I'll be inviting our last speaker for today, but not the least. She's doing a lot of work, and she's also the co-convener of this program. So Professor Dr. Revati Janaki Ram, she's a Vice President of South Zone 2016, and also now she is the president of TNFOG, and she's a recipient of Dr. A.L. Mudlayar Award in DGO University in MD, and she's doing so much of her work. I think the CV is very short over here. And also she has achieved the prestigious Dr. Durusha Community Service Award and Lifetime Achievement Award from IMA Madurai. She has been the past president of Madurai OG Society and president of IMS Madurai, and a very active member of Oncology Committee. She is the South Zone Coordinator for Oncology Committee of FOGSI. I invite you, madam, for your excellent talk. You've been doing a lot of work in that SSNPP app, and to
I can
take
see
people
Dr.
through it.
Walter has logged in from your ID. If he's there
Is
and
it?
he wants to address, I can see Dr. Walter. He has logged in with your faculty.
That should be very wonderful. Dr.
I just saw
Walter, it's a
him,
privilege
with
to.
your faculty ID, I saw.
Jignesh, can you help us out? If Dr. Walter is there, can you take him?
And your faculty ID, Dr. Priya Kumar. We will search. Meantime, Dr. Revati, you can start.
Yeah, Dr. Revati.
Okay.
You just coordinate with Dr. Walter. If he is there, he can address after Dr. Revati. Yeah.
Sure.
Okay. Hope you are able to see my slide, no?
Yeah, very much.
Okay, okay, fine. Good evening, everyone. And thanks to Dr. Priya and Dr. Lakshmi for giving me this great opportunity. SSNPP. I really congratulate Dr. Priya for coining this term, Swasthya Sundar Nari. That is healthy and beautiful woman. Now, what is our role in making her healthy? Prevent the preventable. Prevent what? Prevent cancer cervix. And of course, every one of us doing a lot of work in screening, prevention, and everything. But whatever work we do, documentation as well as reporting is very, very important. That too, if digitally, it will be much, much easier. And this SSNP app, mobile app, was launched on 15th July 2022 in Hyderabad with in hands of Dr. Jean, FIGO President, as well as our FOGSI President, Dr. Shanta Kumari. And this SSNP has been designed to achieve the cervical cancer elimination goal, which goes hand in hand with WHO cervical cancer elimination call by 2030. India leads the globe next to China in cervical cancer incidences and mortality, with one lady losing her life every 8 minutes due to cervical cancer. FOGSI is the main professional body representing 38,000 gynecologists in India, and it also plays a pivotal role as advocates for cervical cancer Mukt Bharat. This SSNP app has been designed by Dr. Priya Ganesh under the guidance of senior FOGSI members, and it has been developed by Genworks Health Private Limited. What does it do? It helps in the implementation of various screening methodologies for cervical cancer as well as breast cancer. And also, it gives a quick and easy user experience for screening. Just a minute. Ready Reckoner for structured screening program for both CA cervix as well as CA breast, and colposcopy reporting with speed scoring made easier for screen positive patients. It provides comprehensive scientific solution for treatment of precancerous lesions, and more than everything, it helps in collecting the Indian data to analyze for the actual condition of precancerous as well as cancerous lesions of cervix. AI-based disease analytics and patient timelines help in assisting the interpretations. Now, this is very, very important. What is the clinical and social impact? It sensitizes the clinicians to screening as well as cancer prevention. Say, for example, once a doctor is tuned to this SSNPP app, all the time it is lingering in the back of her mind, any woman who enters her clinic, maybe for any other complaint, not even for a gynec complaint, if she enters, if she is 30 plus, immediately the gynecologist will think that, yes, I have to do the screening for this woman, and I have to enter in this SSNP app. Not only the patient who is coming with other complaints, but also the accompanying lady if she is 30 plus. Now, this attitude should develop for every practicing gynecologist, so that you, not necessarily that you should go to a camp and organize and go and screen those women. Any woman who enters your cabin for any complaint, 30 plus, think of screening and upload it in the SSNP app. And once you start doing it, obviously it will be in your mind, you will start screening also. And second thing is that to inculcate and emphasize the age-old religious methods of speculum examination and PV. Now, this is really a pitiable situation, because many a times I have seen patients coming with the complaints of HMB, just prescribing tranexamic acid, sending them for imaging, MRI. Like that, not even doing the simple speculum examination. And once you start using this SNPP app, necessarily you have to do all the tests. Okay, that is very, very important. That too in a stepwise manner, systematic manner, right from vulva, vagina, vault, and cervix, everything you need to do in a very quick way, and you cannot miss anything. Okay, so once you do such way, you cannot skip and then move to the next page also. So once you do in that way, you can never miss any lesion in that particular woman. And also it has a strong, impactful Indian study followed by publication. Now, what's the purpose of this app? Quick and easy experience for screening and reporting cases, prevention, screening, diagnosis, treatment, and follow-up all under one roof. Ultimately, it supports the WHO initiative of eliminating cancer cervix by 2030. The details of the patients are stored in encrypted, coded manner in the server, thus the data privacy is maintained. It will only be available to the respective doctor, who at any time can opt to come out of the app, by which all his data will be automatically deleted. And another important thing is that we can monitor the various screening methodologies of cervical and breast cancer being followed up by many gynecologists. This I will show you the impact of it in the dashboard, which I'm going to show in the subsequent slides. And how are we going to, I'll just go quickly, I can show you how we are going to use this app. Main thing is that you should have an Android phone and you open the Play Store and you can just download this SNPP app. This is quite easy and anybody can do that. That is very, very important. And once you download this like this, the next thing is doctor registration. Okay, that is one time. Now here, for the first time, you have to register yourself, enter your mobile number and enter the password. So before that, you have to register yourself, the name, all details like registration number, mobile number. Mobile number is very, very important because this is going to be just like an login ID for you. And once you register, this is a one-time process only. Once the doctor registration is done, easily you can open up the app by subsequently for registration of the patients. Now let us see one by one how we are going to do that. The screening workflow is like this. As you can see here, register the patient, update the medical event by history, start the screening event, update the patient consent, which is also very important, nicely done here. Select the screening procedure, capture the pre-screening data, and then update the screening results. And finally, you can update the diagnostic advice, prescription, and end of the event. All these things can be done. If you take it one by one, now how are we going to do this? Here, like you register yourself by your mobile number and password. You can create your own password and you can start the patient registration. Okay. Subsequently, what you can do is you have to select the event type, either screening, diagnosis, treatment, or follow-up. You choose that. And then subsequently, then you start with the pre-screening workflow. That is, take the patient history, very important, and the past screening details. That is also included, in which whether screening done already, whether vaccination taken already, all those things will be entered. And if they have done undergone screening, they upload the report also. And you can choose whether what is the screening procedure we are going to, either the breast or cervical screening. And most important thing is digital consent is also there, which will go automatically to the mobile or the email ID of the particular patient. And this is very, very important because here the pre-screening information, you can never skip anything at all, like vulva, speculum, everything. And even in the vulva, when you just open it, you mention healthy, bot, growth, scarring, puckering, or altered color. And similarly, if you go to the speculum examination, also healthy, unhealthy, bleeding, ectopy, polyp, just you need to click and then move away to the next item. And after that, you have to decide which test which are going to plan, viability or HPV testing or colposcopy or pap smear, whatever it is. Okay. And then breast examination, also similar things. And once you have done the test, you can just include in this, if the results are awaited, you can just wait and you can upload it in the subsequently. Okay. And once the reports are available, you can enter those reports, and finally you can include the test performed, the diagnosis, advice given, and the follow-up data also. Now, in case you missed anything, you can go back and fill it up and finalize it. At the end, you can submit it. Now, Dr. Priya Ganesh has thoughtfully organized this spreading of this app among the entire India by organizing the zonal leaders, the South Zone, myself, and the West Zone, Dr. Yasodhara and Dr. Veena Acharya, North Zone, Dr. Reena, and East Zone, Dr. Saswati. Under each zonal leader, the state coordinators are there, so that we collect all the gynecologists interested in this, and they are training them or giving them a demo online also. Okay. And having done all these things, let us just have a quick review about what are the results of this app over the past few months. And as you can see here, as on date, it is on 26 Jan 23. As on that date, there were 820 downloads. 20 doctors have downloaded this app, of which 457 doctors have started registering, and total number of registration, like patients registered, are 880. Now, as you can see here, state-based doctors and patients have also been in, and hats off to Dr. Saswati. Assam has given the maximum number of 199, even though they have a smaller number of doctors registered. And next to that, Rajasthan, Maharashtra, and proudly Tamil Nadu also. Okay. And subsequently, what next? We have got next thing is, yeah. This is again a very, very important thing. After screen patients, you can collect how many are normal, how many are abnormal. As you can see here, over the short period, we have got 61% normal, 39% just abnormal. That's all. Now we have to segregate further what type of abnormality they have got. And the type of screening test that has been undertaken, and as the first speaker was telling, the cytology has not yet vanished, and depending upon the availability and affordability, and still this pap smear is continuing as a screening procedure, and the maximum 240 cases have been pap smear. And HPV testing is also on the rise, and more HPV testing are being done for screening, and colposcopy is quite a good number. The credit goes to Dr. Priya, who is going all around India and training every gynecologist in colposcopy. As you can see here, each and every screening method, how many positive, how many negative, how many we are getting this abnormalities in each type of test. Also, you can identify through this app. And again, state-wise and individually also, how many cases we are getting. That's also we are doing. And Assam, again, the maximum. And next is the Rajasthan, Maharashtra, and then Tamil Nadu. And individually also, we are finding out maximum number of cases being registered by doctors, and all these top 5 doctors and top 5 states are being recognized and appreciated. And this gives an encouragement for others also to take it up. Okay. And the feedback from many are like such that the Dr. Devabhadra from Guwahati, he has told that this has helped me keep track of all my patients with the tip of my finger. That's such a wonderful thing, and all are very, very happy about it. And so also Dr. Saraswati, who is here, who has done a lot of registration. Now, last but not the least, there are a lot of challenges, worries also from the participants. Now, the biggest question is, why should I take it? And what benefit do I get? Should I do this or not? Now, this is a big question. Okay. Now, how are we going to explain that? Now, why should we take it? All the benefits which I have explained earlier. Second thing is that for everything we say that every time we have got only Western data. Why not we have an Indian data? Everyone is grumbling on that. And who is going to bell the cat? Who is going to take the job of finding out the Indian data, especially for the precancers and cancerous lesions of the cervix? And I'm happy that Priya has taken up the job, and through this SSNP app, definitely we can find out the clear, actual Indian data for this precancerous and cancerous lesions of the cervix. And second complaint is that there is no time to upload in our busy practice. Not at all. Once you start doing it, it is very, very easy. You can complete the entire thing within 5 to 8 minutes. It is good enough. Okay. And another thing is that not necessary that only the doctor should do it. Even our staff nurses, everyone is well trained in using the Android phone. So they can easily upload it, okay, and you can just check it. That is all, and it is not at all difficult. Okay. And is it necessary to do all types of screening? I don't know colposcope. I don't know. I can't afford to HPV testing and all this. Not at all. Whatever is affordable and it is available to you, you do any screening. That is very, very important, and you can upload in that. And preferably, if possible, you can do this HPV testing, and you have learned a lot about it, the benefits and the easiness of doing that also. And troubleshooting, if you have got any problem in that, there again, no problem at all. You have got all these zone coordinators and state coordinators, zone leaders, and all the numbers are available. And easily you can contact them and get the problem solved. Now, can I have the records of the patient? Sure, everyone. As and when you do that, you will definitely, you can keep track of your patients and all the details. Anytime you can refer. That is a very, very useful thing for every practitioner. So I think this SSNP app can definitely be used by every gynecologist, and by using this, definitely we can increase the number of screening procedures, and we can pave way for the goal of elimination of cancer cervix by 2030. So before I conclude, I would like to say that as president of TNFOG, I have sensitized all the society members in Tamil Nadu to organize free cancer service screening camps in their own area. Just like Dr. Sundari was telling yesterday, district-wise she has been doing it. Now here also society-wise, in their own society, they have to identify the rural areas, and they have to collect the rural women and 30+ women and do the screening. As a starting of it, on 4th of February, we are going to do a mega camp, a screening camp at Dindikal, and for which I have invited our FOGSI Oncology Committee Chairperson, Dr. Priya also. And I am sure with the cooperation of everyone, we can definitely, our ultimate aim in Tamil Nadu is that at the end of 1 year, end of my tenure, the entire Tamil Nadu 30+ women will be screened. And this is going to be a continuing program in future also. And I'm sure together we can and we will. We can determine to reach the goal of elimination of CS cervix by 2020. And I think cancer service during my PG days 50 years ago, it is a dry subject and nobody wants to learn about it because nothing much can be done about it. But now Priya has shown the rosy side of it, definitely how we can prevent it. And her activities as encourage every one of us that I should do something to take up this work and prevent the cancer cervix. And I'm sure all of us join together to eliminate cancer cervix once for all. Thank you very much.
Excellent, madam. It can't be any time better than this. I can't even imagine that this app is really taken up so well ahead that it's really very worthwhile to put all those 3 to 4 years of hardship to get this app on. And again, let me congratulate the team who is behind this. It is Dr. Revati Janakiram, who is SSNPP app South Zone leader. Heartiest congratulations to you, ma'am.
Thank you.
Dr. Veena Acharya, SSNPP app West Zone leader, along with Dr. Yashodhara Gaur. Dr. Reena Srivastava, SSNPP app North Zone leader. And she is handling the whole of North Zone. And Dr. Saswati Chaudhary, who is the SSNPP East Zone leader of complete East Zone. So it can't be anything better because it cannot be done individually. You have to have a group efforts. So thank you very much, Dr. Revati, madam.
Thank you.
And over to Dr. Vidya Thubi, and Dr. Hiralal sir has also joined. So we will quickly take up the feedbacks first from Dr. Vidya, then from Dr. Hiralal.
Yes, yeah, it was a really wonderful. What I must say, the certification course you have designed, and I congratulate again Dr. Lakshmi to taking forward such a wonderful ICOG certification program. And I think icing of the cake on the cake was the app today. And I think there are many questions in the chat box, and most of them I think they are on that postmenopausal. I think one person has asked, I don't remember her name, but she has asked about the postmenopausal colposcopy. I think the answer will be tomorrow.
We will be taking it
up. They want about the Swedish code. I think that will be definitely tomorrow. They will be answered in the management part. So there is very short of time, and I congratulate all the 3 speakers, especially the Walker Pendrivelli. I think
he is joined. I'm very happy, Dr. Walter. You could come up into this.
Yeah.
You can open up your, unmute, and you can.
Because we could not interact with you. We want some comments from you in this certification course about whatever artificial intelligence you were talking of. So especially your comments on that spectroscopy and other things which are creeping in. And I think that is a future of our screening programs.
Okay.
Yes, Dr. Walter.
If there aren't specific questions, I'll just say that I think spectroscopy, which actually originated in India in the 1950s with Raman. Yes, indeed, has been resurrected more recently simply because the interpretation of the signals that are reflected from tissue were so complex that it was very difficult to interpret them. Whereas now with CNN and augmented intelligence, it can be done almost instantaneously. And spectroscopy is now being used in so many different circumstances that I think it's very likely that we will use it in the detection of HPV and indeed perhaps genotyping. I expect it's going to be very much cheaper, and in combination with image interpretation may mean that we have a screening, triage, and treatment selection process that is laboratory independent, cheap, and yet very accurate. It can also be used for vaginal self-sampling as well as urine, but urine I think is more attractive. And I think the early data coming from Manchester, where they're doing a large study of vaginal sampling versus urine, is that there's real equivalence between the two. So it's a very exciting time, but I think we need to wait until the early results that came from the NIH are validated in other studies. And we hope to perform one of those in the immediate future, comparing spectroscopy on urine for HPV with the usual PCR for the detection of HPV. But I'll answer any questions that have arisen, if that's helpful.
Dr. Hiralal, do you have any comments? Thank you, Dr.
Thank you
Walter.
very much. I had a bit of interruption in between, but I have heard all the speakers since the beginning of this late afternoon. Obviously, it appears to me that India is a huge country, huge variability in the resources, settings, and that of the availability. So whatever Revati has highlighted, I agree with that. And to my mind, as a worker, teacher since the beginning of '84, going on all the government medical colleges, we have got the setup of routine cytology screening. Obviously, depending on the resources and choice of the patient, that could be changed. Apart from that of the cytology, that of the primary HPV screening, or combined where resources again permit combined, that has been said that a high sensitivity to the extent of 99% combine that HPV as well as cytology. So this is one. Whatever resources we have got, we have to go for this screening whenever the woman comes to the gynecology clinic. As Revati has mentioned, not only that, this major part of the gynecological death, malignancy, cancer death, apart from that of the breast cancer also. So these are the two essential points that I feel. And regarding the treatment point of view, again, then depending on the situation and resources, whether it should be that of the ablation, like that of the cryo, to that of the excisional procedure, lift, and the ledge procedure, whatever, and that of the conization, depending on the case that we have to go, and depending on the resources again. See and treat is usually a good procedure provided well screened cases. And then while we are going with this, as because the FOGSI guidelines that HPV vaccination, that for especially in our clinic, the adolescent girls, whenever they are coming, they are the optimum age that we should start the vaccination. We should stress on the vaccination also as a preventive program. Now then, whenever we have done the treatment diagnosis of abnormal cytology, CIN 2, 3, and that of the treatment procedure, again then follow-up is important. We should not think that once the treatment is done, that is over. Then again the patient should be followed up by cytology at an interval of 6 months, depending on the situations of CIN 1 or 2, and that of the available resources or HPV combined with that of the cytology. So these are the thing, and obviously new thing that, and regarding that of the awareness, probably I would believe that awareness of the patients, our patients, women in our country at the moment, no less than my experience of working in the international field also, there is no less in awareness amongst the women. They are very keen to have the cytology screening. So once we should discuss, counsel, and then give the support and do the procedure, and follow-up is again not a problem. They are very happy these days, almost every woman having the mobile. So they could be followed up with the report. They should be given this adequate followed-up treatment also. So my feeling is this, with this awareness and that of the FOGSI, the leadership, Dr. Pai, Dr. Lakshmi, and the different zonal coordinators that they have started, I believe we are going to have very soon the impact of downtrend risk of that of this dated cancer. Very soon we are going to see these changes. This is my feeling, my observations, and since that working in the teaching institutes, the government medical colleges, where we see several hundreds of patients in our clinic. Thank you very much for this
Priya,
very much informative oncology preventive session.
Me, please.
Yes,
And I also congratulate ICOG and FOGSI for the working practices, the protocols, and the quality standards we have to maintain, and the certification course. This will definitely is going to help all of us to have some standards, and of course the audit. Sure. And the app definitely is going to help us to bring out the various zonal, what is the percentage, what type of the practices we are taking away, and the research, for the research purpose also that app is going to help us. Congratulations again, and thank you for inviting me as a chairperson. Thank you.
Thank you very much. I think all the speakers have done an excellent job, and the faculties and the
Excellent,
chairpersons
excellent, yeah.
also have really taken their time to sit back for all the 4 hours. I think it was a huge 4 hours. And Dr. Walter, you have been able to join. Dr. Sabira, you have been able to join. And now comes our a word from Dr. Lakshmi, and then our post evaluation.
No, I just want to extend my special thanks to our international faculties, Dr. Walter and Dr. Sabira, and of course to all our national faculties, speakers and chairpersons for making this course so informative and useful for all of us. So let's go ahead with the post test. Yeah.
Yes. Thank you very much. Dr. Mala, over to you, and Dr. and Jignesh to share the link. Dr. Mala, are you there? Dr. Mala?
We can start post test. Jignesh?
Okay, all right. So
yeah,
Jignesh will be now sharing the post test link.
Yeah.
And we all
will
be a little quiet for 10 minutes.
Yes.
Yes, thank you very much.
So friends, link is already shared. The countdown has started. Please start solving the questions. After 10 minutes, the link will expire.
Lakshmi, what happened to that question of post-menopause alone with that of screening procedure?
Which one, sir? You are muted.
The squamo-columnar junction in
Yeah.
the postmenopausal woman will not
Usually
be,
it moves up. It is a columnar junction that many of our speakers already mentioned that it is not a static. It is a dynamic zone. It moves up and down. Say, for example, in adolescence, in pregnancy, it comes down. In the postmenopausal phase, it goes up. So while doing this smear, that of the surface smear as well as endocervical brush or the broom is essential. And if need be, when we are going for colposcopy, there should be the squamous junction must be seen. For that reason, there are some endocervical speculum is there. So speculum could be used. This os could be dilated, spread out, and that vision could be made with that help of a colposcope. So this is the advantage of using that endocervical speculum. And
thank you, sir. But I would rather, thank you, sir, but let this post test be over so that there won't be any confusion. And then we will have the comments and your suggestions, sir.
Right, right.
I'm so sorry to interrupt you, but
no problem.
Candidates need not be getting disturbed. Yeah.
No, it's a wonderful session.
Last 1 minute, dear delegates. That's done. And now we'll be sharing the right answers.
Good evening, everyone. I congratulate all the participants who had participated in this pre-test and post-test sessions. And I'll just share the answers to you. First question, primary HPV test.
Can you show that? Can you share the?
Yes, ma'am. Yes,
Mr. Jignesh, please show.
Yes, ma'am.
Primary HPV test for a virus called high-risk HPV virus that can cause cervical cancer changes to develop into cervical cancer. True. Can HPV test be done instead of pap smear? True. An HPV test can be done by collecting a sample from cervical canal, vagina, both A and B. Answer is A, that is cervical canal. In which year the latest Bethesda system for reporting cervical cytology was reported? Answer is 2014. In the latest Bethesda system, 3 levels of CIN is replaced into 2 levels, that is LSIL and HSIL. True. What is the Bethesda system used for? Answer is C, that is both reporting cervical and vaginal cytological diagnosis and reporting pap smear results. What is the most common histology of cervical cancer? Squamous cell carcinoma. What is CIN1 stage? Answer is A, used for low-grade changes in the cells that usually go away on their own without treatment. What is CIN2 stage? Answer is B, used for moderate cellular changes. In VI, how much percentage of acetic acid is applied to the cervix? Answer is B, 3 to 5%. VIA screening test is reported negative if the answer is A, acetowhite lesions are not observed on the cervix. VIA positive means presence of acetowhite epithelium, usually near the squamocolumnar junction. True. Villi screening test is reported positive if the answer is C. The area turns densely yellow on application of iodine. What does Villi test involve? Answer is B. Lugol's iodine. Dull white plaques with ill-defined borders are considered LCIL, and those with sharp plaques and thick edges are considered HCIL. True. ISC markers for cervical cancer screening is B, that is P16. ISC markers test is done on a sample of biopsy tissue collected from the patient under observation. The sample can be fresh or frozen tissue collected during a biopsy. True. CA 125 is raised in which condition? Answer is D, that is all of the above: pregnancy, TB, cervical cancer. AI technology has been used in colposcopy and magnetic resonance imaging to assist in the diagnosis and staging of cervical cancer. True. What are the advantages of AI in cervical cancer screening? Less time consumption, reduced need for technical personnel, reduced human waste errors, all of these. AI can automatically recognize images, extract features, learn classification, and process data using complex algorithm. That is true. What are the prerequisites of colposcopy? Avoid scheduling colposcopy during periods, not to use vaginal intercourse the day or two before the colposcopy, not to use tampons the day or two before the colposcopy. All of these, and the answer is D. Colposcopy is performed to diagnose. The answer is D. Genital warts, inflammation of the cervix, precancerous changes in cervical vaginal tissues. Colposcopy evaluation is done by sweet score. True. What is SSNPP Act? That is, answer is Swasth Sundar Nari Prevent the Preventable. In SSNPP app, users can attach multiple reports. That is true. When was SSNPP app last updated? The answer is B, that is 3rd October 2022.
So these are the answers, and we have
23, I think, was misprint when the pre-test, but in the post-test we corrected it. And I hope everybody got it right.
Yes. Dr. Lakshmi, madam, your comments?
Going on very well. It's a long, hectic day. So, Priya, you can give your remarks and then we can wind it. Day 2, and I hope to see you all again tomorrow on day 3.
Thank you, madam. I know it's a long day. We have sat all the time from 3:30 to 8. It can't be anything better than this. Almost 2, movies.
Ice time.
Great job.
All right.
Yeah, you have done.
Thank you very, very much. All the faculties, I should thank all my faculties, that is our speakers, our chairpersons, all the delegates. What patience. Truly, I mean, wonderful participations. Cannot finish my whole thing by saying thank you so much from bottom of the heart to Mr. Jignesh and Nilima, our ICOG staff, who have been really supportive all the way. And it cannot have been possible unless and until they would have given that wholehearted support at the backhand team to develop their PPT slides and everything. Thank you very much. We meet everyone tomorrow at 3:30. That's 4 o'clock. Good night.
Yeah, on behalf of the chairs, we thank you both profusely for your patience, for the sake of education, academic learning, for all the students all over the country. That's a great job you have done.
And hearty congratulations.
Thank you.
Thank you, sir.
Yeah.
Thank you very much.
Great
Meet
job.
you all tomorrow at 4 o'clock.
Yeah.
Yes.
That's the last day.